Yes.
Yeah, yeah. I have two presentation from Mojai Hodain in the last few days before is presented in our uh, webinar in PON. So what is the functional neurosurgery? Functional neurosurgery is the unique branch of neurosurgery dealing primarily with the disorder of function rather than disorder of structure. So we usually modulate the function to become a normal function. And uh, the difference of the another branch of the neurosurgery is, for example, disorder of structure like a tumor, spine, or vascular. This is a disorder of structure, but in function we evaluate, we develop, we learning, and we doing by of the disorder of function for such as movement disorder, pain, epilepsy, or psychiatric disorder. This is the field of the functional neurosurgery. So,
Lost sound, Doc.
Okay.
okay, the first speaker is Dr. Ahmad Fahmi, consultant, which topic is surgical procedure detail in stereotactic brain lesion. Time is yours, Dr. Fahmi.
Okay, thank you very much, Dr. Madinda, and all of my all my teachers. Thank you very much for this opportunity to share about the physical property for stereotactic emotion. As we know that physical, what is brain mentioning? Brain mentioning it means that it is a mix of brain mention on the brain. And the art is the very important thing for the listening. If you do this strictly, make the lesson too big, it will make the complication. And if you make the lesson too small, it will be recurrence of the tremor. What actually is done for the lesson? Our target usually for tremor is will be thalamus or for the definition for the GDP, it seems to GDI. And nowadays, we looking at what the PPC mentioned, quality economic calculation. It is not like 100% normal life, but it can improve the quality of life of especially for Parkinson's disease or Parkinson's tremor. This is manageable for Parkinson's, especially in the dementia and disability. The first time we must know it is Parkinson or the secondary Parkinson. If there is idiopathic Parkinson, it will be we need to keep the drug from the neurology, and then if it is unresponsive, I think it is not idiopathic Parkinson. Maybe it is included in the secondary Parkinson. If it is respond, we must know it is of every day, out of the day 24-hour detection fluid, or it is on off. Yeah. On off it means that after it is medication, the patient will be fluid, and after 1 hour, it will be better. If it has effect or not, it is indication for intervention. And it is different for tremor. If for tremor, if it is response, we will need any surgery, but if it is unresponsive, we can use thalamotomy. It is accuracy that we can use for thalamotomy. It is the electrode. Usually it is variative, the diameter and the thick. Usually we use 1 millimeter, 1 millimeter of diameter and 2 millimeter of thick. In the other surgeon, they are doing with 4 millimeter of thick with 1 millimeter of diameter. And we use usually monopolar. default there is many electrodes that available for bipolar. Use monopolar for bipolar. This is the technique. Yeah. The first time we implant on the stereotactic apparatus, stereotactic frame. It is very important how we implant this. Usually, about to make the screw not too tight. If we are doing this too tight, if we compress the bone, and it can make like pneumocephalus or epidural hematoma. It is very important. And after we put the frame, we, we bring the patient to the MRI. MRI. Like the two patient is we need the sequence for MRI. 1 millimeter thickness, no spacing, no overlapping. You can use sequence T1, T4, T2, SBE, and T2 flat. Especially T2 flat. Please consider to using T2 flat because you can see the anatomical of the brain clearly. And then after MRI, we bring the CT scan. If we use this, it's very cool. If you put the fiducial box, please make sure that this is not this fit clearly. It's very fit with the frame, the frame. Must be very good placement. And then we doing the CT scan, and this very important step too. Use fusion. The fusion between the MRI and CT scan is very important. If the fusion fails, you can make some big error to the listening or implant DS. And after the fusion, we, we, we use the target, there is the target, and we can bring the exclusion in the OP. During surgery, this makes sure that the patient can evaluate the awake surgery. So we can evaluate the effect of our method of stimulation. Before operating theater, please make sure infusion tract. Yeah. Please make sure the infusion tract. Please make sure patient already go to the restroom before and with prophylaxis antibiotic. MRI, 1 millimeter thickness, no spacing, no overlapping, sequence T1, FSPDF Bravo, T2, different flares, 1 or SBE, and can be done with on the frame using MRI. Nowadays, during MRI, we didn't use the frame and we use the fusion. This is frame installation. This is very important. Please make sure it is parallel to the ECTC. It is the trick. Yeah? The trick to minimize the error. Minimize the error to make this parallel to SBNTC. Apply skin anesthesiology ointment. Yeah, sometimes we doing the ointment before the injection. Always monitor blood pressure. Be careful. Yeah, be careful. The patient sometimes can be shocked. Okay. And then prepare dexamethasone and sulfasalazine. Sulfasalazine is patient shock. We can use dexamethasone and sulfasalazine to treat for the shock. Make sure the electrode in the target area. It is in the center, yeah, in the center of the stereotactic. You can look like this. And the frequency stimulation, we use sensories. Frequency is 50 Hz and close with 150 microseconds. Increase the current until 2.5 milliampere. Evaluate the clinical signs and symptoms. This is MRI presented before, and this is the CT scan. Please make sure the CT scan is cover all the fiducial area. Please make sure like this. 1 millimeter thickness, all fiducial area coverage. imaging technique, full frame MRI and CT scan, or the second one is MRI without frame, CT scan with frame and make occlusion. This is the second technique that we have done here. Stereotactic software, MRI and CT scan fusion, ACTC, target position, combined technique. You can use coordinate-based, structure-based, technique, and trajectory. Please make sure do not pass the sulcus. Don't pass the vertical. Left to left, right to left, not pull back. Yeah. It is very important. In the surgery room, patient position, please make sure this is the cervical of the patient for the airway. For the airway position, please make sure the airway is very good. Vital sign, blood pressure. Please look at the blood pressure first and always communicate with patient, because during the surgery, patient usually confused and anxiety, worry about the surgery like that. Yeah, please make communication with the patient. Environment, ask every personal quiet, not too noisy in the surgery room, and sometimes we doing the fly instrumental music. It is for draping. Yeah. Usually we not make all of the hair shape, not just a little hair shape. Equipment, sharp perforator. Please make sure that the perforator are sharp, not too long to do the hole. Double, triple check during install, coordinate, and in every step. Take care of the electrode carefully. It is the method that we use to make sure the electrode in the center of the stereotactic. Positioning technique after sensory and motor stimulation. Make a temporary lesson with 45 degrees Celsius. Evaluation clinical sign and symptoms. If improved, make a permanent lesson with 75 degrees Celsius in 30 seconds. And then always evaluate sign and symptoms of the patient. Always. Target, we have two techniques, direct and indirect. For direct, usually we do for the like GPI or the STN, subthalamic nucleus. But for indirect, usually for PRN or PTT, because we cannot see clearly the PTT or PRN in the MRI. We can use coordinate methods or create technique. This is what we do for the PRN patient. Make a multiple lesion, it is after the surgery. Make a multiple lesion in the target and in the posterolateral of the target. The diameter of the lesion about 3 until 4 millimeters. It is we use 3 hole for like for stereotactic, using the center and the posterolateral, like this. No bone dust. Yeah. Please clear the bone dust after the perforation, after the hole. Make a stimulation, trial lesion, make a trial lesion, and make a lesion. This is in this picture. Be careful if there is a pain after the bone. Yeah, avoid this. And this is another picture. Avoid the electrode touch the diameter or bone, because it can make a bending. The electrode will be bad and the target will not good enough. And please make sure this is in the zero. It is not good and must be in the zero. And please make sure the patient during stimulation is okay. It is, for example, it is the face. The face has a pyramidal tract. If it is happen during surgery, you must stop the stimulation and move to another place to during the stimulation and make a lesion. This is our what we do for stimulation. And then after stimulation, we doing the 45 degrees Celsius until 30 seconds. And then for permanent lesion, 75 degrees Celsius until 30 seconds. This is the lesion. During surgery, we evaluate the tremor. The tremor, after we put the electrode, usually the tremor will be decreased because the micronization of the electrode. Yeah. It means that we are in the good place of the PRM. It is in the good place. Evaluate the patient during surgery. Many activities, writing, doing something, yeah, whatever that the patient complains before surgery. And then be careful. Be careful. Yeah. Please look clean the equipment by yourself because if it is happen, the electrodes will be sliding and it is not accurate again. Big consideration if you want to do bilateral. In fact, it can be dysarthria or mutism, especially in thalamotomy, in old age, more than 55 years old, be careful. Old person and severe brain atrophy, be careful if you want to do the bilateral rationing. What to evaluate during surgery? Movement of the arm, hand, and leg, tremor, rigidity, writing, and other activities that patient complain. Face. It means you will not just evaluate the hand, but you must evaluate all of the body movement and all of the body complaint of the patient. Speech, dysarthria, and five issues, issues. The eye, it is any light blinking, eye gaze, any ophthalmoplegia or other. This last the video before, yeah. We look the face. It is pyramidal track. It means we are in the wrong position. Evaluate the patient during the surgery. Yeah. Even during playing piano, we do the surgery. We evaluate the patient. The tremor is already gone or not. And the another mentioning is polygotomy. Target posterocentral GPI effective for dyskinesia, chorea, general dystonia, or head dystonia. This is the target, yeah, the posterolateral of the GPI. And then this is the MRI after, yeah. It is bilateral polygotomy. Please be careful if doing the bilateral polygotomy. Yeah. It is we avoid this procedure now. Yeah. It is after bilateral polygotomy. The patient, before the surgery, the patient has a rigidity, bradykinesia, and difficult to turn the body like this. And this is after the surgery, after the polygotomy. The rigidity, the bradykinesia already gone. The patient has a better quality of life. It is for DBS. For DBS, be careful during doing DBS. Please make sure we are in front on the right target. Yeah. Usually, we use the C-arm in the operating theater to make sure the lead still in the right target is doing something. During surgery. If before surgery, like this, if we are doing in good position, in good surgery, it is before surgery, patient difficult, yeah, difficult to move, all of the body difficult to move. And this is after the surgery. After the surgery, it is better, yeah, better. All of the day, patient is like this, yeah, with medication and with DBS. The patient very good. Post surgery, patient can mobilization 1 day after patient can work with patient medication. Do not directly stop the medication. Try to separate drugs. This is usually sent by neurologists. And wound care 1 week after and 2 weeks after, patient evaluation, evaluate the patient 3 months after. No overconfidence. Yeah. Many other people and track ahead. Please be obsessive. More patient, more careful. Be careful. Most important thing is patient selection, treatment decision, and respect is very important. It is the difference between braination and DBS is braination, of course, is cheaper, DBS more expensive. Braination permanent lesion, but the DBS we can adjust. It is the advantage of the DBS, adjustable. The braination is permanent lesion, but the braination no need to change the battery. Yeah. Next lesion, braination. It is just micronation and next stimulation. For still sometimes in the young generation, it can be a psychological problem. Okay, thank you. I hope it is very clear to know that the braination must learn this carefully and be precise from the patient selection until the surgery is possible. Every step is very important. Okay, thank you very much. Thank you.
Okay. Thank you, Dr. Fahmi, for your complete and step-by-step presentations, step-by-step of the procedure. This is very clear for us to know how to make surgery, stereotactic surgery in the movement disorder. To doing discussion. For the first time, I invite panelists, maybe Professor Sainal, Agus Turhan, and Dr. David have a question for the speaker, please. From panelists, maybe there are comment, question, or statement.
It's a very nice presentation. No sound?
Yes, yeah, we heard the sound, but there's no video from you, Dr. David. So,
yeah, but your sound is very bad quality from.
Yeah.
I cannot hear properly here. I'm sorry.
In Dr. Fahmi presentation, Doc.
First, I very appreciate very nice presentation from Dr. Ahmad Fahmi. Congratulations for your success for this functional surgery. I just want to ask you if you compare with lesioning with the gamma knife, like a gamma knife, which one do you which is the positive and which is the negative gamma knife to compare with your do since the procedures are almost the same. We use a stereotactic based on Lexus frame. Thank you.
Thank you. Thank you very much, Dr. David.
Yes.
Question. It is the lesson for the brain. Of course, you can do with gamma knife, but for this area, for the functional surgery, is the direction of the edema after the gamma knife. Yeah, please be careful for that, especially for the palidotomy. The palidotomy is nowadays in the historical time, it's done by gamma knife too. But nowadays it's avoided. Yeah. It's not done by gamma knife too because the lesion for the palidotomy it's very the edema is very big.
Yeah.
We avoid to doing with gamma knife now. And Malamotomy maybe we can do, but
Yeah.
just make sure the edema is not too big because it will be problem for the patient. Okay.
Yeah. Thank you, Dr. Fahmi. From now on, the thalamotomy is very 100% succeed with gamma knife. It's very easy. Maybe if we compare for the cost, maybe almost the same with your procedure. Thank you.
Yes.
Okay. Maybe Dr. Fahmi, you add some statement for that? No?
No. It's
Okay.
correct. It's correct. That we can do with gamma knife too, especially thalamotomy.
Yeah.
But for palidotomy, please be careful of that.
Yes.
Thank you very much. That's it.
Okay. Thank you, Dr. David,
Yeah.
for your question. Is there any question for panelists, or maybe attendant or participant can make a question by type in Q&A question?
Mas, dari saya, Mas.
Oh ya, silakan Prof.
Then
Silakan Prof. Sen.
Oh, ini video.
Mohon izin, Prof masih mute, Prof. Oke.
Sudah ya? Oke. For Mas Fahmi, thanks for the nice presentation. And then we know that the cost for DBS is very expensive, yeah. So and I know that you have so many cases of lesioning, but only few DBS. So we just heard from Professor Taira that he left DBS, yeah, for making lesion, yeah. And now my question is it possible for developing country like Indonesia, if we do not use DBS, we just do all cases with lesioning? Is there any cases for movement disorder that cannot be done by lesioning just for DBS only? Is there any cases? Because I hope that we may develop lesioning to spread it up in many parts of Indonesia, not DBS. Thank you.
Okay. Thank you very much. Thank you very much, Prof. Nowadays, we can do especially for the patient selection, usually we must move the Parkinson primary Parkinson, not the secondary Parkinson. Usually for the patienting, we can do for the Parkinson patient, But with the very good indication, especially for the unilateral. But sometimes in on-off Parkinson, it is difficult to take an on every day, 1 day for the lesioning. It should be doing DBS, I think. Then I already consult some patients too with Prof. Taira too about the on-off patient. Yeah. On-off patient can be solved by DBS, but other of the complaint of the patient, we can do the lesioning, but not the on-off patient.
Okay.
Especially with tremor. Of the dyskinesia, or like this morning presentation of Taira, he doing the PPT lesson. The PPT lesson we already done earlier. It is good for tremor and the dyskinesia and rigidity in the unilateral. Like that. I think we can think of the brain mentioning in patient with Parkinson, but especially for the on-off patient with Parkinson, it is sometimes difficult.
Yeah.
In the Prof. Taira hand, it is really good.
Okay, thank you.
Thank you, Prof.
Yo.
Thank you, Prof. Zainal.
Yeah.
Okay. We have 2 minutes left. If you any question again, Dr. Agus Turhan or Okay. So if there is no question, maybe in the next presentation we have Dr. Muhammad Agus Aulia presented with movement disorder surgery also. Maybe we can ask in that session also. So we move to next presentation provided by Dr. Heri Subianto, consultant neurosurgeon in Surabaya, with the title is in a mini pteronal approach for anterior temporal lobectomy, amygdala hypocampectomy, surgical nuances by Dr. Heri Subianto. Time is yours, Dr. Heri.
Okay, thank you, Dr. Inggas. Is it clear, my voice?
Yes, more clear.
Yeah.
Then,
Okay.
yeah.
Thank you for committee for giving me opportunity to share our experience, and also I would like first, before doing my presentation, I would like to give a special thanks also for Professor Zainal Mutakin for teaching me. I have a long memory with Prof. Zainal in Semarang. Thank you, Prof. Zainal.
Yeah.
So right now I would like to present my topic about mini pteronal craniotomy. Is it in the view, Dr. Ingas?
Yes, Dr. Heri is good.
It's good.
Yeah.
Okay. So we would like to share our experience of doing mini pteronal approach for anterior temporal lobectomy, amygdala hypocampectomy. So this is a mini pteronal approach for standard anterior temporal lobectomy. This is where the hospital where we are doing our surgery. As we know that epilepsy affect around 1.5 to 1% of the world population, and 20% to 40% of all patients will remain refractory to medical management. And epilepsy surgery itself still remain underused worldwide. This also include in Indonesia also. There are some paper from Indonesia state that in Indonesia also underuse of epilepsy surgery. And as we know, in the United States of America, less than 1% of patients with drug-resistant epilepsy are referred to epilepsy center. And the average delay from onset of epilepsy to surgery in America is more than 20 years. This is Indonesian population. This is actually from Prof. Zainal, and I do some update with population estimation in 2020 around 2,073 million. So if it is 1%, then we have 2.73 million epileptic patients, and 30% of it is around 819,000 patients will have drug-resistant epilepsy, and half of these actually will have benefit with epilepsy surgery. But in fact, maybe it's very less patients who come to our daily practice and asking for surgery. That is our problem, and that's why we have to do communication with all specialists connected each other. And temporal lobe surgery, as we know, this is one kind of epilepsy surgery that if we perform this, the rate of successful is very high. It's around 70 to 80% seizure-free chance if we are doing this in patients with temporal lobe epilepsy. And the standard anterior temporal lobectomy, as described by Spencer, is like question mark like this, question mark incision, and then craniotomy that include also frontotemporal craniotomy. And then with this kind of incision, we are doing the anterior temporal lobectomy and amygdala hypocampectomy. This is usual the standard approach for anterior temporal lobectomy. What is our background of doing this mini pteronal? One is because as we know, there are many papers that showing how technology is driving the landscape of epilepsy surgery. This is one paper in Epilepsia. It was in 2015 or 16, I forget about that. This is how technology will help us of doing small and maybe minimal invasive surgery. The goal is to minimize the morbidity and then to get a better outcome and also and all. And one paper also coming from India, which showing endoscopic epilepsy surgery emergence and new procedure, which is come from Professor Sarat Chandra. This is also showing how innovation in epilepsy surgery comes until now. And then one paper also, mini craniotomy for standard temporal lobectomy, a minimally invasive surgical approach, which come from Professor Otaibi in Saudi Arabia. This is also showing how this approach become very good in terms of reduced morbidity and also better cosmetic result. But in this paper, what they are doing is they are using neuronavigation to do all of the procedure. And as we know in Indonesia, we don't have all neuronavigation in our hospital. So the standard anterior temporal lobectomy usually using question marks, skin incision, and frontotemporal craniotomy, which is mini pteronal. As I would like to share is we are using surface anatomical landmark without neuronavigation, but we would like to reduce morbidity in terms of, for example, post-craniotomy pain, and we would like to get better cosmetic result, which is a white scar formation. Usually, we will do we want to get a lesser scar formation, and also we want to avoid depression of the lateral sphenoid or anterior temporal. So as pre-surgical evaluation, we have to check all of the patient pre-surgical evaluation because this is mandatory. One is semiology. Semiology and pre-surgical evaluation, Dr. Yuris will talk about this. What is the most important is there should be concordance between semiology, video EEG, ictal video EEG, and MRI with epilepsy protocol. All must be concordant in one side of temporal lobe. If there is another ictal seizure in another part of the brain, for example in the occipital or in the frontal, then don't do this approach because we need to put maybe some recording, intracranial recording and all. And then after this all confirmed, all in one concordance in one side of the temporal lobe, what we should do next is to do MRI evaluation. I mean, we have to see the MRI and then we have to learn what is depicted in the MRI. For example, for this patient also have ictal seizure in the right temporal. From the MRI, we know that there is amygdala enlargement and also blurring white and gray matter if we compare with the left temporal side. So I have to measure the length of the temporal, and then I have measured the length if I move from the superior temporal gyrus until I comes into temporal horn, how long that will take. This is some of the preparation that we have to do and check and recheck again the MRI of the patient. So what is the surface anatomy? Surface anatomy, as we know that we have to know exactly where is the Sylvian fissure. We can calculate this Sylvian fissure using condylar line and posterior ear line, and then we draw a line from the lateral margin of the orbita to the 3/4 of the circular from the nasion to the occipital tubercle. And then this is how we drawing a picture. This is the line. We don't do straight, but we are doing a little bit curved, so we can exactly know where is the Sylvian vein during the surgery. And then patient will be in supine position with general anesthesia, and then head rotated to contralateral 70 to 80 degrees, and then elevating the ipsilateral shoulder. And then microscope maneuver, this is also one of the most important during surgery, because if we want to see the temporal tip or the tip of the temporal lobe, we have to do some maneuver in the microscope so we can see exactly the tip of the temporal lobe. And then the surgical procedure, this is semilinear skin incision. We start with 1 centimeter above the syncoma and 1 centimeter anterior to the tragus, and then we extend it vertically 6 to 8 centimeter to the level of superior temporal line. And one of the most important thing is also we have to do craniotomy over the superior temporal line, make sure that we can see clearly the Sylvian vein. We do craniotomy. This is the frontal. This is the right side, right standard ATL. This is the frontal. This is the temporal base. This is the occipital. We do craniotomy 3 centimeter in diameter, cross incision of the diameter, and then we are doing identification of the Sylvian vein and the superior temporal gyrus. And we do measurement from the tip of the temporal pole, how many centimeter from our opening. So we put the usually penfill number 1 we put, and then we do the measurement how many centimeter long are we. And then another step is, first time it looks like the brain not relaxed. That's why we have to do corticotomy of the superior temporal gyrus to the base of the temporal lobe, and then we are doing to the anterior along the Sylvian arachnoids, and then we are doing a section of the temporal tip. And then after that, we have to do identification of the Sylvian arachnoid posteriorly to find the temporal horn. And the next step is as the same as the standard anterior temporal lobectomy, which is lateral disconnection, and then anterior disconnection of the amygdala and all, then medial disconnection. One of the most important when we are doing incision, we have to preserve the muscle, the temporal muscle, and because we put retractor, it is important to put retractor inside the temporal muscle. We try to avoid the temporal muscle. We try to avoid if we do retraction for many long without loosening it, then there will be some hematoma or contusion in the temporal muscle. So we have to avoid that. This is the surgical procedure. This is the right anterior temporal lobectomy as depicted from the first slide. So this is the frontal, this is the temporal lobe, this is the occipital. This is around 2 centimeter craniotomy, 2 to 3 centimeter craniotomy. I hope the video is moving very good without delay. So the first is we are doing the opening of the dura mater. Usually we are do with cross incision of the dura mater. And then here, as we can see, this is the Sylvian vein. And then from this, what we do is corticotomy to the temporal base. Corticotomy to the temporal base until we can see the arachnoid layer in the temporal base. And after that, we are doing corticotomy along the sylvian vein until we can see also the arachnoid in the base of the anterior temporal pole. And then we cut the anterior temporal pole. This is the anterior temporal lobectomy. And we have to make sure that there is no rest of the brain cortex in the arachnoid of the base. And this step is we are looking for the arachnoid in the sylvian fissure. One we know, we can track it posteriorly from the arachnoid, and we can find the temporal horn. So this is the amygdala, this is the head of the hippocampus, this is the uncal rhesus. After that, the next step is doing lateral disconnection, and we have also track to posterior. Yeah, this is the lateral disconnection. We take the lateral temporal cortex from the collateral sulcus as the margin. Actually, the step of this is the same as the standard step. And after doing the lateral disconnection, we are doing the anterior disconnection, and this part is the medial disconnection, which we have to see the inferior choroidal point. And from this part, with pen fill number 1, we do hippocampectomy. It is important not to use cauter at this part because we are afraid of injury because of the head of the bipolar, it can injure the peduncle of the cerebri. We have to this is the posterior cut of the tail of the hippocampus, and this is the hippocampal artery. This is the only artery that we can coagulate and cut, because here also there is choroidal artery. So we must not coagulate and cut the choroidal artery, only the hippocampal artery. This is the rest of the anterior part of the amygdala. We have to make sure that we can see the arachnoid and also the arachnoid as a barrier, which means that we cannot move forward if we see the arachnoid. We have taken the hippocampus, and now we are sucking the rest of the brain cortex in the arachnoid of the temporal base. This is the part. This is the place where the anterior part of the amygdala. We have to suck out until we can see the arachnoid of the sylvian. This is the final inspection. And then for closing, we usually put back the bone with 2 mini plates, and then I only stitch the membrane of the temporal, not all the temporal muscle, the outer membrane of the temporal muscle only. And then we are using clip for the skin. And this is the CT evaluation. As we can see, it is around 2.037 centimeter, and the length is around 8 centimeter, 7.5 centimeter. And this is 1 month after surgery. As we can see that it's quite small incision. So this is case number 1, female, 38 years old, age onset 9 months, worsening at 60 years old, normal development, seizure frequency 6 times per month, 1 to 2 times minute, provocated by emotional and fatigue. Patient has aura, abdominal discomfort, and nausea. Maximal asymptomatic period is 5 days, and medication, phenytoin, Depakote, and change to bambitol and clobazam, but still patient still have seizure. And neuropsychology evaluation, we find impairment of left temporal lobe, and then this is the MRI. As we can see here, this is the hippocampal sclerosis, and there is also blurring of wet and gray matter also. And from the etal video EEG, it shows the left temporal discharge. This is a post-surgical CT scan, extubated, and the result was focal cortical dysplasia type 1B. And this is 3 months after surgery. It's almost difficult to find where is the incision. This is case number 2, female, 24 years old with normal developmental, age of onset 1 year, seizure frequency 1 per 3 weeks, but it is clustering, disabling, and provocated by emotional and stress. Patient has abdominal discomfort with aura abdominal discomfort, and then develop nausea and vomiting. Patient has already taken phenobarbital, Depakote, Keppra, and clobazam. And the neuropsychology evaluation, we found impairment of the left temporal lobe. This is the MRI. Also, we can find there is hippocampal sclerosis also, and blurring wet and gray matter. And the etal video EEG showing left temporal discharge. This is the surgery, and this is the CT after surgery. Histopathology found focal cortical dysplasia 1B with hippocampal sclerosis. This is case number 3, male, 24 years old with normal developmental, recent education is bachelor degree, age of onset 8 years, with seizure frequency 3 times per week, disabling, provocated by emotional, fatigue, and cold bitter. Patient take Depakote, bambitol, and clobazam. Neuropsychology evaluation, impairment of right temporal lobe with etal video EEG showing right temporal discharge before. This is the MRI. We find also there is some hiss in the tail of the hippocampus, but the histopathology, it was gliotic kyst, and during surgery we try to resect also this calcified, but it was, the hemodynamic was not stable. That's why we put it, we left it without resected it. All 3 patients has angle class 1, 3 years follow-up, and this is case number 4. Male, 19 years old with normal developmental, undergoing bachelor, age of onset 14 years, with aura deja vu, seizure frequency once per week, impaired awareness, oral automatism, and then focal to bilateral seizure 1 per year. Patient take Depakote and phenytoin, optimal dose, still have this seizure. And then neuropsychology evaluation, impairment of the right temporal lobe, extended video EEG showing right temporal discharge. From the MRI, we can see that there is blurring white and gray matter, also amygdala enlargement. This is the AFL scan. We can see the perfusion also decrease in the right temporal. We are also doing minipteronal craniotomy approach. And then the histopathology also showing focal cortical dysplasia type 1B ILE. And this is the post-operative result. Case number 5. Patient 6-month follow-up, no seizure, no aura deja vu. Patient number 5. Patient number 4. And then case number 5, female, 47 years old with normal developmental, age of onset 27 year, with aura abdominal discomfort every day since last year. This is interesting because this patient walking around to the specialist. She went to internal medicine and doing endoscopic, nothing found, and then she also another surgeons also doing CT abdomen, but nothing found also, because what she feel is the abdominal discomfort, which is come almost every time daily. So the semiology is impaired awareness, oral automatism, focal to bilateral seizure, seizure frequency once per month, but develop to disabling or clustering. She already take Dipacot, Phenytoin, Gabapentin, Riclona, Carbamazepine, extended video EEG showing right temporal discharge, PET scan showing right temporal hypometabolism. This one is a little bit confusing actually. That's why I asked patient to do PET scan, and from the PET scan we know that there is hypometabolism. Actually both sides, but left right side is more than left side. And then patient and family agree to the surgical option. And then histopathology also showing focal cortical dysplasia, ELE type 2A with hippocampal sclerosis. Right now, there is no aura anymore. 6-month follow-up, no aura, but she still take medication. What is the limitation? For this approach, we have difficult to perform direct cortical mapping because our opening is quite small. So patient selection is important. It is not suitable for all kinds of temporal lobe surgery. And then sometimes mouth opening, we have some mouth opening limitation because of the self retractor, but these retractors must be placed under, that's why this retractor must be placed under temporal muscle and sometimes must be lost up. Actually, from these 5 patients, there is no patient which have this mouth opening limitation. For the conclusion, minipteronal craniotomy with semi-linear skin incision for standard temporal lobectomy is safe and effective as standard approach, and then excellent cosmetic result can be achieved with this approach. But it is important to select patient based on semiology, video EEG, and MRI, because this approach is not suitable for all case of temporal lobe. Thank you.
Thank you, Dr. Harry, for your nice presentation with very many kind of the case. So we have 10 minutes left to make a discussion.
Okay.
Okay. For the first step, I want to invite panelists. Please, maybe Dr. Zainal or Dr. David.
Rumah sakit. Undi mau. Undi. Okay.
Okay. Is there maybe panelists may have a
Thank you, Dr.
Dr. Yuris dulu, enggak Dr. Yuris dulu.
Oh, please, Dr. Yuris, if you have any question for Dr. Harry.
Presentasinya Pak Yuris kapan nanti?
Oh, nanti dok, Prof. Di sesi yang berikutnya kita istirahat.
Oke. Ya, kalau gitu
Okay.
ya sudah, saya dulu ya.
Ya. Can I make a question for Dr. Harry?
Silakan.
Yes, please. Yeah. According to your case, several of cases you have still their tip temporal left in your surgery field. Is there any influence of the seizure, for example, why you left in the tip of temporal lobe till the residual, not totally removing from in your surgical technique?
Yeah. Thank you, Dr. Ingas, for the question. Actually, I usually spare the superior temporal gyrus left in situ, especially after it is 3 centimeter from the tip. 3 centimeter from the tip. So what we see, it is the part of the superior temporal gyrus which is 3 centimeter after the temporal pole. But in the temporal pole, I resect all the temporal part or the gyrus. But the superior temporal gyrus, which is 3 centimeter from the temporal pole, usually I leave it because, as we know, there is some hearing center also in the superior temporal gyrus. And according to the Spencer also doing this 2.5 to 3 centimeter of the anterior temporal pole resection and sparing the superior temporal gyrus. And that is enough if we compare with selective amygdala hypocampectomy only. So because of this, usually I spare the superior temporal gyrus.
Okay. Okay. If any question from the attendant, and we have 5 minutes left.
Dari saya Mas ya kalau tidak ada.
Ya silakan.
So epilepsy surgery is a functional surgery. Yeah, it means that we should do the surgery as best as possible. Yeah.
Yeah.
What the patient want is cure from the epilepsy. Yeah, actually. So incision does not matter so much. Yeah. If we should do larger incision, it is okay. Yeah. But if we may do it smaller, it is okay too. Yeah. But the key point is surgical morbidity should be near zero for functional surgery.
Sure.
Yeah. Functional surgical morbidity should be near zero. It means that we need to understand the anatomy, of course, for those people who want to start doing epilepsy surgery, we should work together, like Dr. Harry. Dr. Harry joined the surgery in Semarang for 1 year, and then and every month he come to Semarang.
I think more
2 to 3 surgery every month.
I think it is more than 1 year, Prof.
More than 1 year, yeah. And then after Semarang, he went to India, for 1 year again. So because the case is so many and it is all over Indonesia. In Semarang, we have performed more than 700 epilepsy surgery, but those patients, 40% are coming from Central Java only. 40%. Another 40% from Java Island, from DKI, from East Java and West Java, another 40. Only 20% of the patients come from other islands. Yeah, it means we need to develop this surgery in many other places, especially the Neurosurgical Education Center, teaching hospital. Yeah, and in Semarang, we have 5 to 6 cases every month. We are ready and we welcome to anyone from other centers who want to study epilepsy surgery. Yeah, and the second I want to comment because on the last PIT bedah saraf before this, there is some presentation about doing epilepsy surgery caused by cavernoma. Yeah, I think caused by cavernoma using the neuronavigator. Yeah, I want to say that the most important of this surgery is taking out, removing the epileptogenic brain. So if there is lesion such as cavernoma, AVM, for cortical dysplasia, or other lesions, the most important is not taking the lesion. So the purpose of epilepsy surgery caused by other lesions such as cavernoma is not removing the cavernoma, but removing the epileptic brain. There are epileptic brain surrounding the lesion. So what we need is not a neuronavigator. The most important, if you have lesion, yeah, is doing the electrocorticography, intraoperative EEG is most important to know the border of the not just the lesion but the epileptic brain. Yeah, so I suggest better to start with what Harry does, what Dr. Harry does is non-lesional, yeah, hippocampal sclerosis. And if you have other lesion, we call it double pathology. In cases with double pathology or in cases with extratemporal epilepsy, we need to monitor EEG during the surgery. Yeah, electrocorticography. Yeah, not the neuronavigator, but electrocorticography. Do not mislead, because I don't want this epilepsy surgery in Indonesia misled to the wrong direction. Okay, thank you very much.
Thank you, Prof.
Thank you very much, Professor Zainal.
I agree with Prof. Sarat. Like our third case, which is we have some gliotic in the tail of the hippocampus. What we are doing is not take up the gliotic or we do we don't know actually what we think that it was a tumor. What we are doing is not take up the tumor, but based on the pre-surgical evaluation and all,
Yeah,
it's showing that the right temporal is also affected. That's why we also resect the right temporal. And even the lesional structure is still there. Patient is seizure-free 3 years until now.
Yeah.
So epilepsy surgery is quite different with like cavernoma surgery or tumor
Yeah.
surgery. It is
Yeah.
something really different. Thank you,
Yeah.
Prof. Zainal.
yeah.
Thank you, Prof. Zainal. Thank you,
Yeah.
Dr. Harry, for your nice discussion and very informative for us. It's for maybe a young neurosurgeon here in Indonesia. This is important for you all. Okay, before we go to the next presentation, I will back to the host to some information by the sponsor. Please, Dr. Dir. Dr. Dira.
Yeah, we will have some
Silakan.
sponsor. Sponsor will show the for our event here. Okay. Okay, thank you for the time. Can we continue the session again, Dr. Made?
Okay, thank you, Dr. Dira. So we move on to the next session speaker. Also, here, Dr. Heri Subianto, consultant neurosurgeon in Surabaya. He will speak about percutaneous ballooning compression for trigeminal neuralgia. How I do it. You have 30 minutes. Start from now, please.
Thank you, Dr. Ingas. Is it clear?
Yes. Go ahead. Good.
We would like to share our experience of doing percutaneous ballooning compression for trigeminal neuralgia. Actually, why we share this? Because once it is difficult to get the specific device for this procedure. And then second, we have a needle for radio frequency, but for the beginner, it is very dangerous if we are using sharp radio frequency needle, which is sharp. So it is very dangerous. That's why we would like to share our experience of doing percutaneous ballooning compression for trigeminal neuralgia. So trigeminal neuralgia, as we know, it is recurrent, transient, and severe pain in the trigeminal nerve area, manifested as electric shocking, knife cutting, and tear-like pain, with prevalence 182 per 10 million and annual incidence is 3 to 5 per 10 million. The treatment option usually drug therapy, radiofrequency thermocoagulation, percutaneous balloon compression, stereotactic radiosurgery, and because we are a neurosurgeon, usually we are doing microvascular decompression. So what is the indication? Based on our experience, we do this especially for elderly patients, which is it's difficult to do long surgery, general anesthesia for a long time, or sometimes patient has comorbid like some high hypertension or chronic kidney disease or something like that. And then second is recurrent trigeminal neuralgia after microvascular decompression. And then the third, we also have patients who prefer percutaneous balloon compression rather than of doing microvascular decompression. So what is the background? Because first, there is no specific device. It's not available in Surabaya. And then if we compare to radio frequency with sharp needle, percutaneous, this is wrong. Percutaneous balloon compression with this technique is more secure because of the blunt needle from the DBS cannula. We are using DBS cannula. And then the other is with fluoroscopic technique and the general anesthesia make the procedure is easier to do and safe for the patient, comfortable also for the patient. And then in the Journal of Neurosurgery, March 2016, percutaneous balloon compression is superior also than percutaneous retroglycerian glycerol rhesolysis with lower incidence of dysesthesia and then lower incidence of corneal hyperesthesia, and then the technical failure also decrease if we compare with percutaneous retroglycerian glycerol rhesolysis. So patient will put under general anesthesia in the cath lab room, and then what device that we use Fogarty number 4. Sorry to mention the type. We usually use Edward because the Edward has a small tip, so we can insert into this DBS cannula. So we have tried also another type of Fogarty number 4, and we cannot insert into DBS cannula. So that's why we use this type, this mark. And then Surflow number 14, this is DBS cannula. This is steering number 3, and this is number 1, and this is 3-way. Patient supine slide extended under GA. Usually the anesthetist will choose which one is better, endotracheal tube or laryngeal mask, but usually we ask for endotracheal tube, and then soft gel head donut, and the insertion point is 2 cm lateral from the corner of the mouth. In cath lab, because we are using fluoroscopic, so it is easy for us, and we can see also how many degree this is from epi, how many degree lateral. We can memorize, and the position is like this. It's like we use the classical C-arm. We've been doing with C-arm, but cath lab is preferable than C-arm. And this is the foramen ovale. From the fluoroscopic view, we can see this part is the side of the foramen ovale. One is we insert the Surflow 14, 2 cm from the corner of the mouth, and then after that, with this help of needle holder or longer dentate, we try to aim this Surflow into the foramen ovale. And then once convinced, we take this Surflow 14 and we change with the DBS electrode insertion tube. And then again, we try to drive into the foramen ovale. We drive the cannula to Meckel cave through the foramen ovale from the lateral position. Usually, we will observe the decrease of the heart rate. It means that we are in the correct position. And because of the tip of the cannula is blunt, it's more safe for us, and we don't afraid to do injury to the vascular structure or another. So once it is confirmed, we usually after we enter the foramen ovale and go to the space of the Meckel cave, this cannula will fix, and then the advantage of this also, because patient in general anesthesia, patient will not move and patient won't feel pain during the procedure, and this cannula will stay fixed. Once it fixed, we remove the inner cannula, and then we insert Fogarty 4 into the cannula until the tip reaches the tip of the inner cannula. We can observe this in the fluoroscopy. And then we make marker 1 cm from the outer part, because we have to drive this Fogarty 1 cm inside and past the cannula of the DBS. So we drive forward. We can observe also the heart rate usually decrease if we have observed that the insert Fogarty, inner Fogarty, has passed 1 cm, so it is safe for us to inflate. So we drive, and then we remove the inner stylet. We change to 3-way cannula, and we use 3 mm syringe and aspirate the air. This is another step also. We cannot move, because we need to get good peer light view from the contrast. That's why we have to aspirate the air. This is the aspiration, and we close the 3-way collector. After that, we put 1 mm contrast material in 1 mm syringe and make sure there is no air inside. After that, we open and injected slowly and observe also the heart rate and to ask the anesthetist to watch carefully. So, as we can hear the sound of the heart is per light, and patient becomes bradycardy. So it means we are in the correct side. Usually the bradycardy will resolve by itself, but we have to inform the anesthesia. If it is happen continuously, anesthesia will give atropine or another drug. Yeah. Once the bradycardy becomes normal, we have to lock the syringe and we have to maintain this sphere-like shape for at least 5 to 10 minutes. Yeah. Yeah. So we have to maintain. Close the three-way, wait 5 to 10 minutes inflation of the Fogarty. Once finished, we aspirate the contrast material and then while observe also the fluoroscopic view, make sure that the sphere-like shape disappear. And then we close the three-way connector. And then another important step is we have to remove this Fogarty along with the cannula together. This will avoid the chance of because this balloon material is quite fragile, it will avoid the chance of lifting part of the Fogarty in the foramen ovale. We take together. So this is Fogarty and the cannula. This is the small wound after procedure. What about the outcomes? Actually, we have performed around 6 patients and relief of the pain directly after procedure. And patient will develop facial numbness, but without muscle weakness. And this facial numbness also will decrease along the time. And we have also experience of doing this with sedation only, with C-arm, but it is not comfortable for the patient. So with the general anesthesia, it is comfortable for the patient if we compare with sedation only for procedure. So percutaneous ballooning compression under GA is safe and comfortable for the patient. This is minimal invasive. It is pain-free after procedure with low incidence of complication. And fluoroscopic helps surgeons doing procedure better than C-arm. Thank you.
Okay. Thank you, Dr. Harry, for the nice presentation also with, I think this is a modified cannula by the DV cannula, yeah?
Yeah. Dr. Indra, you have many cannula. You can use that.
Yeah. That's a good for use for this, yeah. Okay. Next up with our discussion, we have 15 minutes left. Maybe our panelists can have a question or statement. Please, Dr. Agus Turhan, maybe. Okay. So, before maybe the panelists have a statement. Maybe I have a question for you, Dr. Harry.
Yeah.
So, in the maintenance of inflation in the ballooning by the contrast, you said that it should be waiting until 10 minutes. Is need for that long, or do you need for maybe shorter time but repeated inflations for balloon? And how about we drive another angle for make larger compression, for example?
Yeah. Yeah, thank you very much, Dr. Inggas. Actually, in one of the article, it is enough of doing inflation for 3 minutes. For 3 minutes is enough. But what we are doing 5 to 10 minutes, and sometimes 15 minutes without to inflate. We want to make it sure that we have do the compression to the metal cave, to the Geigerin ganglion. And what if we do some another trajectory? Usually it's quite difficult to drive to another trajectory. That's why our idea, if we do static in one position, but we make it longer than the usual time.
Okay.
So we can avoid change the directory.
Yeah. Okay. I grab your idea. There are one question from the attendant. How long the effect can be grabbed? For example, for 1 year or for something. How about your follow up?
Yeah.
For this patient.
Yeah. Actually, this the gold standard. If we find some neurovascular compression, microvascular decompression, MVD is the gold standard procedure. Because this procedure, we don't remove the neurovascular compression. So sometimes the pain, the trigeminal sensation would come back. So usually we inform the patient our procedure lasting maybe until 2 years. We call until 2 years. This based on journal actually. But luckily, alhamdulillah, all patients still pain free until now.
Good.
We have also one patient. I have performed microvascular decompression, and then patient still have painful sensation, and then 3 months after microvascular decompression, patient went to another center, and then they perform radiofrequency thermocoagulation. But 1 week, the painful sensation increased before, and patient came back to our center, and we did percutaneous balloon compression. We did in last year, and until now it's 6 months. Patient still send message to me, and her husband said that the painful condition is controlled.
Okay.
And another tip is don't decrease the medication directly after the procedure, because usually patient take carbamazepine. It is important to tapering the medication directly after the procedure.
Okay.
Yeah.
There are 7 minutes left. We have 2 questions.
May I?
Go ahead, Dr. David.
Okay, thank you very much, Dr. Harris, for very nice presentation. Both of your presentation earlier is very nice. First of all, we know the trigeminal neuralgia management. The first choice is microvascular decompensation. We know
Yes.
of course that's almost 90 until 100% we can do make a patient better. But I don't have experience with balloon compression. But for many years ago, we do the PRGR, percutaneous retrograde glycerol rhizotomy. Our series is very good. Usually, the recurrent is run only in the first years, and then we do the second procedure, PRGR, that just make a very long pain-free. But unfortunately, there is no right now. It's very hard to get a absolute glycerol. I don't know, because no pharmacy want to make it absolute until 96 until 98% glycerol. It's very cheap, and nobody want to make it anymore. Right now, pharmacies only make 92%. That's why we already forget it, the PRGR. For your procedure is still use general anesthesia. As we know, for the earlier people, it's very sometimes it's not tolerate with general anesthesia. That's why maybe we at that time and that case I think I go to Gamma Knife. Since Gamma Knife in journal is only 1 year will be back recurrent, and we can do the second one until the patient dies. Of course, until now the Gamma Knife is still expensive, especially there is no national insurance cover it. BPJS until now is still not cover the Gamma Knife. Almost the same with your epilepsy. If the BPJS can cover the procedure of Gamma Knife, I think that is one of choice for very light of a procedure without general anesthesia. Thank you.
Thank you, Dr. David.
Thank you, Dr. David, for your statement and additional. We have one question from Ricardo Quinones for Dr. Harry. The question is, why do you like this procedure? And why do you do under general anesthesia? Please, Dr. Harry.
First question, why do you
like
this procedure?
Yes, why you prefer, or why you prefer this procedure?
As a neurosurgeon, we are neurosurgeon. I prefer doing microvascular decompression, MVD. We are doing MVD almost every week. But some patients who cannot tolerate to general anesthesia. That's why elderly patient with comorbid of core problem, or because we already perform MVD and then patient have trigeminal neuralgia again. So we offer to do this. And we also have one patient refuse to do MVD. We offer microvascular decompression, but patient refuse. That's why we are doing this procedure. If somebody asks me or Dr. Fahmi maybe, because we are doing this together with Dr. Fahmi, Dr. Fahmi teach me much of this procedure. If somebody asks me, which one do you prefer, MVD or this procedure? We would say MVD is our preference because it is directly go to the cause of the problem. We can decompression neurovascular contact. That's for the first answer, first question. And the second, why we are doing with general anesthesia.
Yeah.
Before doing with general anesthesia, we do this under sedation. With sedation, patient will feel painful. First, patient can see our needle. Wow, it's quite big, doc. Oh, I'm afraid. Then they change to move. We have put enough local anesthetic, but patient still move. And once it's entered the Meckel cave, patient becomes painful sensation again. Move, and we think that it is not safe for us. So we change to laryngeal. And laryngeal also it thinks that we communicate with the anesthetist. Please do sedation. Once patient develop bradycardia, we change to laryngeal. And we have experienced one patient. We do only sedation, and then during the procedure becomes bradycardia, and then the anesthetist, and then they do intubation with laryngeal mask. So it's not safe. For me, it's not safe. So that's why in the last 3 procedure maybe, we do this directly under general anesthesia. Once we can saving time, and then second, anesthesia can control all the vital sign of the patient. If there is some bradycardia, they will put atropine and all, and they don't afraid with the airway obstruction because they already put the intubation. We have discussed this with the anesthetist also, and they feel that it's better of doing this with GA directly, and shorter time procedure also we can achieve with this directly GA.
Okay, so you did with the one day care. Can we doing by 1 day care, or must be inpatient for one night overnight, Dr. Harry?
Actually that depends on the insurance.
Yeah. Okay. The last question.
David, do you have any comment? Actually, this is 1 day care.
Day care.
Sometimes.
Yeah.
The one day care.
Yeah. One last question, because the time is near up. What the contraindication of this percutaneous ballooning procedure? Contraindication.
So far, for us, there is no mandatory contraindication as long as anesthesia ready to do general anesthesia. We do this procedure.
There are no absolute contraindication.
No absolute contraindication, yeah.
Okay. Thank you, Dr. Harry, for your nice presentation and discussion. So,
thank you so much.
Yes.
I would like to say thanks also to Dr. Ahmad Fahmi and Dr. Agus Turhan.
Ya.
Okay.
Boleh, Mas.
Silakan, Prof.
Ya, Mas Heri. Diterangkan tolong patofisiologi hilangnya nyeri akibat dikompresi selama 10 menit itu. Apakah karena iskemi? Is it because ischemia of the Gasserian ganglion or other mechanism? Kalau itu, if it is ischemia, for how long does the pain relieve? Will it come back again sometime? Thank you.
Thank you, Prof.
Yeah.
I think we need to do this in another section of webinar.
Oh, okay.
Actually, what we do is we distract the pin fiber. I forget the C fiber or another fiber. What we are doing is we try to disrupt this pin fiber. That's why, Prof. But
Okay.
this is
Yeah.
not a definitive. This is not a definitive. That's why if we know that there is some neurovascular contact, it's better to do microvascular decompression. But some patients refuse to do surgery. That's why we do this. What we are doing is try to disrupt the pain fiber, nociceptive pain fiber. With longer time, we hope that this disruption will take longer also. The effect will take longer also with long time of inflation.
Okay. How about Dr. Prof now? It's enough?
Yeah, that's
Right.
enough for now.
Okay. Uh, thank you for the speaker. Thank you for all panelists. Thank you for attending. We waiting for the next session, but in between we waiting for the sponsor presentation. Please, Dr. Dira.
Thank you. We will add another sponsorship from the electronic and UMJ. Yeah. Okay. Thank you. Can we continue the session again, Dr. Made?
Okay. Thank you for Dr. Dira for the time. So we moved to the last session in this the first seminar. Yeah. The speaker is Dr. Ferry Sanjaya, neurosurgeon from the Siloam PBC Kupang, with topics is management of upper plexus injury. The time is yours, Dr. Ferry, please.
Okay, Dr. Made, thank you for the time. Good afternoon, everyone. So, without further ado, I will start with my topic. The title is Management of Upper Plexus Injury. I hope everyone can hear me clearly. Pardon the background noise.
Okay, it's clear.
Okay. So, our topic for today is we're going to discuss about brachial plexus injury, and in particular for upper plexus injury. And in this case, I will discuss about one of the key management of patients with brachial plexus injury, which is nerve transfer. We discuss about the principle of nerve transfer, and a case report with a long-term follow-up. So moving on. So we all know that brachial plexus injury is the most severe form of neurological involving the upper limb, and it's affecting largely young and productive populations. Most of my patients are they're teenagers or young adults that have this unfortunate accident typically from motor vehicle accident. And of course, it will cause a significant functional impairment and disability with psychological and also economical impact. Unfortunately, the clinical recognition and management of brachial plexus injury is often delayed due to the nature of the injury itself. Some patients they have head injury as well, with decreased consciousness, so the symptoms and signs of brachial plexus injury was not identified at the moment of injury. They probably will notice that there is a weakness in the arms, upper injury, and also for the some patients, the physician itself sometimes they have a ultra conservative management in this case, so they typically wait for quite a long time, waiting for a sign of recovery. Just yesterday, I did a nerve transfer of upper plexus injury, and the patient only wait for 1 year and 3 months because the initial physicians who manage his case is still waiting for signs of recovery. After 1 year, there's no recovery, and they send the patient. As a result, patients often lose potential function or recovery of the upper limb if it's not managed properly. So again, the mechanism of injuries most often occur as a result of post trauma, which is a traumatic stretch injury. The supraclavicular roots more often involved in the intraclavicular plexus. And of these supraclavicular injuries, glute avulsion present in 75% of cases. This is very important. We will discuss about why the identifications of glute avulsion is very important, because it will affect the treatment or the strategy to try to improve the patient's outcome. So based on the mechanism of injury, brachial plexus injury is divided into 3 general forms, which is the upper plexus injury, which involves C5 plus minus the C7, all is the F. Duchenne palsy, and the lower plexus, which involves the C8 and C1, all is the Compton-Sturgeon palsy. This is actually not very common. And of course, the last form is the one that involves the whole plexus, all this the panplexus injury. So most often it's the panplexus injury, and the second type is the upper plexus injury. I haven't seen lower plexus injury myself. It's not very common. This is another complication which we also need to understand. So brachial plexus injury is also subdivided into preganglionic injury or postganglionic injury, meaning that in preganglionic injury, the injury happens prior to the dorsal root ganglia, while for the postganglionic injury, the injury occurs distal to the dorsal ganglia. For preganglionic injury, typically because it involves fractions of the small rootlets, it usually causes avulsions of those rootlets. In this case, chance for spontaneous recovery is non-existent. So we have identified these patients with preganglionic injury. We should perform the surgery as soon as possible. And nerve grafting is not an option. We have to do nerve transfers, or in late cases, might do another strategy, constructive strategy. For postganglionic injury, it can cause a stretch or a rupture. Rupture is also very uncommon, mostly stretch injury. And for stretch injury, there's a propensity of nerve regeneration, but we need to evaluate whether this patient has a spontaneous recovery or not. And once we decided the patient has no signs of recovery, we have to intervene. There are some clinical signs of glute avulsion. Clinically, we can see phrenic nerve palsy. Usually, patients have no respiratory complaints, but we can see it by doing an X-ray, which shows symptoms like. Why? Because the phrenic nerve, the branching point of the phrenic nerve is very close to the foramen. So if the phrenic nerve is involved in the injury, it is more likely, or it's very likely, that the injury is preganglionic in time. And also rhomboid and serratus anterior palsy for the same reason. And then from imaging, X-ray, CT myelography, or MRI, and electrodiagnostic test. This is also very important by doing EMG. If we find normal sensory nerve action potential, patients with dense hypoesthesia or anesthesia. So, for example, patients with normal median snap but has anesthesia involving the C6 dermatome, it's very likely the patient has an avulsion. One thing that I need to also add here, I often see patients who have EMG days after the injury. I don't think it's necessary to do EMG so fast after the injury. So typically we wait for 2 to 3 weeks after the injury, waiting for the Wallerian degeneration to occur completely. If we do the EMG too early, we might get false results. We may get a normal functioning nerve in the case of patients with radioplexus injury. Thus, patients with incomplete or incomplete Wallerian degeneration, we still can see some response from the EMG. So I usually do the EMG 3 weeks after the injury. So again, this is a picture of patients with serratus anterior and lumbar palsy. You can see the wiggling of the scapula here. You push the arm backward. You can see the wiggling is more prominent. And here, patient with Horner syndrome, involving left side. And phrenic nerve palsy, we can see better with the X-ray. So we do X-ray with full inspirations and full expirations, and we see the movement of the diaphragm. So if we don't see any movement on the diaphragm on that side, on the injury side, we know that there's a phrenic nerve palsy. So another sign of root avulsion is from CT myelography or MRI. So in CT myelography or MRI, you can see pseudomeningeal here. But please note that the presence of pseudomeningeal can only shows you that there's an injury to the brachial plexus. There's a possibility that it's a root avulsion is also occur, but it's not a guarantee. So in patients with root avulsion, we don't always find pseudomeningeal. And in patients with pseudomeningeal, it's not always root avulsion. So MRI and CT myelography is not very important in diagnosing the patient. Most important, I think, is from the clinical evaluation, proper clinical examinations, and EMG. I myself, I never do MRI or CT myelography to diagnose the patient. So for brachial plexus stretch injury, in majority, the clinical presentation is usually grade 2 to grade 4. And the recovery, of course, is different. For grade 1, which is the mildest form of nerve injury, typical patient will recover by himself in 6 to 8 weeks. So maybe we see patients with complete paralysis of the arm, or monoparesis. But after, say, 1 month, he starts moving his hand, so his finger starts to flex. He can move his hand, but still having paralysis of the shoulder and the elbow. So in this patient, he's actually harboring a predominantly upper plexus injury and neuropraxia of the lower plexus. So just to remind us again about the clinical gradations of Seddon and Sunderland classifications of nerve injury. So Seddon divided nerve injury in 3 types of nerve injury, which is neuropraxia, axonotmesis, and neurotomesis. So neuropraxia correlates to grade 1 Sunderland, while axonotmesis correlates to grade 2 to grade 4 Sunderland, and neurotomesis is correlated to grade 5 Sunderland. So in neurotomesis, basically what we see is a gross discontinuations of the nerve itself. So who needs a nerve operation? So nerve operation is indicated for patients who fail to improve clinically and acutely by 3 to 4 months. So we need to do exploration and reconstructions, repair or graft or transfer as appropriate. So intraoperative examination or intraoperative EMG is also a very important part of doing plastic surgery, but we will cover that probably in the next topic. For preganglionic injury, there's no chance for spontaneous recovery, so we have to operate early. So again, for nerve repair options, we can do nerve transfer, which we will go deeper on the next slide. We can do nerve graft if the proximal nerve is still functioning, which is not an option in nerve avulsion or preganglionic injury. Or we can do, this is also a nerve conduit or nerve tube. It works exactly like nerve graft. So what is nerve transfer? Nerve transfer is the repair of a distal innervated nerve element using a proximal terrain nerve as the donor of neurons and direct axons, which will reinnervate the distal target. The concept is to sacrifice the functions of a lesser valued donor muscle or muscle with redundant innervations to revive the functions in the recipient nerve and muscle that will undergo reinnervation, or the target that we have set, which muscle we're going to target to give the patient the most functionality. So this is just an example. So intercostal nerve to musculocutaneous nerve transfer. So what we do in this ICN to MCN transfer is we took branches from the intercostal motor nerve, typically ICN 3, 4, 5. I usually use 3 nerves. And then this is of course a functioning nerve, and then we connect it to the involved musculocutaneous nerve. For example, a patient with upper plexus injury or pars plexus injury, which in this case the musculocutaneous nerve is not functioning. So we divide the musculocutaneous nerve, we cut it, and we connect it to the intercostal nerves. So what are the advantages of nerve transfer versus nerve graft? So in nerve transfer, we do the nerve palpation very close to the target muscle, as close as possible. While for nerve graft, we have to do the treatment or the nerve repair at the site of injury. So let's say in patients with brachial plexus injury, you have to explore the plexus, the supraclavicular or the infraclavicular region, and then we have to identify which are the plexus, the components of the plexus involved. We cut the involved part, and then we connect it with nerve graft. Usually we've taken the nerve graft from the sural nerve. We compare it, let's say, if we try to reinnervate the biceps, we do Oberlin plus transfer. We do the nerve transfer at the site of the bicep itself. So the distance from the donor to the bicep itself is probably only maybe 2, 3, 4 centimeters. While you compare it to nerve graft at the neck region, the distance from the proximal part of the nerve population from the sural nerve graft all the way to the bicep might exceed maybe probably about 30, 35 centimeters. And this is very significant because we cannot let the muscle not receiving its innervation for too long. Because if the muscle is deprived of its innervation for too long, for a rule of thumb is for 18 to 24 months, the muscle will lose its function. So once the nerve reaches the muscle, maybe 3 years after, there's no use for that. So shorter distance means earlier regeneration. And usually it also means better results in general or theoretically. So again, the golden standard for flexural repair is, whenever possible, is nerve graft. But it's been shown that nerve transfer can give the patients the same result or even better. So most nerve transfer can be accomplished without the use of an interposition graft or nerve graft. This is also very important because if we use nerve graft, it also will reduce the nerve, the axons that is across the site of injury to the target nerve. The longer the nerve graft, the result is usually even worse. So whenever possible, try not to use the graft. Okay, so I covered that one. So the downside for nerve transfer is that donor site rigidity has loss of muscle function from the donor nerve. Of course, by doing nerve transfer, we have to sacrifice a functioning nerve or a functioning muscle. In this case, of course, we have to choose which muscle or which nerve which can be sacrificed safely without causing a more significant deficit to the patient. And this is the same thing. So the muscle that nerve has been used for transfer will not be suitable for muscle transfer. That's why we have to choose our finger wisely. And this is another problem which is also very important. The need for central communication to have functional recovery. Take it, for example, for ICN to NCN nerve transfer. So we're asking the intercostal muscle or the intercostal nerve to do elbow flexion. For younger patients, it's usually easier for them for their brain to have that how do you say that? To have the brain plasticity to use the functions of the intercostal nerve, which usually interprets the intercostal muscle to breathe, and now to use it to flex the elbow. There's of course a what do you call physical rehab to help the muscle relocation, but this is still quite a significant problem, especially in elderly patients. So moving on to the case report, this is a 6-year-old boy with right shoulder abduction and elbow flexion weakness falling from a cycle accident. You can see here the picture on the right side, upper right. Patient is asked to abduct the shoulder, which he cannot do, which is lift or shrug the shoulder and tilt his body to the side to lift the arm, but there's no actual abduction from the shoulder. And on the picture below, I asked the patient to flex the elbow, which is not existent. He was 5 months away from the injury. And on examination, we see that the bicep, deltoid, interspinatus, brachioradialis, and supinator was grade 0. The rhomboid and surface anterior palsy were also present. So clinically, again, there's also anesthesia involving the C5-6 dermatome. And then absence of bicep and brachioradial reflexes. And on X-ray, we see elevated right diaphragm. And on EMG, we see decreased median CMAP amplitude with normal median SNP. And there are patients of deltoid, biceps, and spinatus. So clinically, you can see that the patient is presenting with C5-6 palsy. And he was 5 months away from injury with no evidence of recovery. And from the EMG showed the patients of deltoid, biceps, and supraspinatus. And so we can see that it's already 5 months away. We can see signs of denervation from the EMG, no signs of recovery. So he must be more than neuropathic injury. So this must be greater than grade 1. So either axonotmesis or neurotomesis, right? Grade 2 to grade 5. And we found rhomboid and surface anterior palsy, and from X-ray we see elevated right diaphragm, which shows phrenic nerve palsy, increased median CMAP amplitude and normal median SNP, which shows that this is a very proximal injury, not a preganglionic injury. So our diagnosis and management and planning for this patient is upper plexus injury, C5-6, preganglionic type. We know in this case we have no chance, or the patient has no chance for spontaneous recovery. So we don't need to wait further. So nerve repair is indicated. And anatomical plexus reconstruction using nerve graft is not indicated because it's a preganglionic injury. And nerve transfer is, of course, the only options we have. So the next one, we have to consider which muscle we want to target. So in priority for brachial plexus injury, the first function we want to recover is elbow flexion. Because it is the most important function from the upper arm. And then the next one is shoulder abduction. So for elbow flexion, what I did was a double fascicular transfer or median or Aurelian cross transfer using the donor from the median nerve and ulnar nerve to biceps and brachialis motor branches. And then for shoulder abduction, I did spinal sensory nerve to suprascapular nerve transfer to innervate the supraspinatus and infraspinatus. And then also tricep motor branch taken from the radial nerve to the axillary nerve transfer to reinnervate the deltoid. So surgery was performed at 6 months after injury. So these are the marking for surgery. So this is for the Aurelian cross transfer, which is the median and ulnar nerve to biceps and brachialis motor branch of the musculocutaneous nerve. And the incision at the supraclavicular fossa is to do the spinal sensory nerve to suprascapular nerve transfer. And posteriorly, at the back of the upper arm, is to do the radial to axillary nerve transfer. So this is the supraclavicular plexus exposure. So this is rostral and that is caudal. This is lateral and this is medial. So here we see the upper trunk, and this is one of the early branch of the upper trunk. This is the phrenic nerve. In this case, it was not functioning. We tested with nerve stimulation. And then the anterior scalene is here, but it's already divided. Already did the anterior scalenectomy. And these are the 3 branches, the main branches of the upper trunk. So the suprascapular nerve can be identified as the lateralmost division or the lateralmost branch of the upper trunk. And this is the posterior division and the anterior division. This is a small branch of the subclavius muscle. And going back again, this is the supraclavicular nerve, which is a cutaneous nerve, sensory nerve. Please don't identify this as the brachial plexus. And here is the, you can hear it, this is the donor, which is the spinal sensory nerve, which innervates the trapezius, divide it as distal as possible, and use this as a donor. While the recipient is the supraclavicular nerve. So again, this is the rostral, caudal, lateral, and medial. This is the upper trunk. This is the suprascapular nerve, which already been divided and turned to the lateral. And this is the spinal sensory nerve, which was traversing here, and it's already taken and brought to the medial side to connect it to the suprascapular nerve. And then the second procedure is Oberlin cross transfer. So the classic Oberlin transfer uses the fascicle of the ulnar nerve and transfer it to the bicep. So what I did, or what I usually do, is that I use 2 fascicles, one from the median nerve and one from the ulnar nerve. And we transfer it one to the biceps and the other one to the brachialis. By doing so, we reinnervate 2 muscles which both work as elbow flexion. So by doing so, we hope we can achieve a better elbow flexion. So this is the exposure. This is proximal and this is distal. This is the median nerve. This is the ulnar nerve. These are the cutaneous branches of the medial and tibial cutaneous nerve. And this is the musculocutaneous nerve. It has been divided, so you can see that it's loose. So in nerve transfer, we cut the donor nerve. So there's no chance for spontaneous recovery, because we know there will be no spontaneous recovery. So any recovery that we can achieve by doing procedure is we can conclude that it's coming from the nerve transfer rather than a spontaneous recovery. So we took 1 fascicle from the median nerve and 1 fascicle from the ulnar nerve. Here, I connect the ulnar nerve to brachialis and the median nerve to bicep. This is the bicep. This is the motor branches. One fascicle from the median nerve here. Of course, there's a technique to choose the fascicle. So basically, what we choose is the fascicle of the median and the ulnar nerve that is predominantly innervating the wrist flexors. Don't use the sensory nerve, because if you use the sensory nerve, it's not going to work. So in this case, we need a nerve stimulation at least. So this is the double fascicular transfer or the oblique cross transfer. Median nerve, one fascicle, and connected to bicep. This is the ulnar nerve with one fascicle and connected to brachial motor branch of the muscle. And then the third part is the tricep motor branch to axillary nerve transfer. So we identify the axillary nerve at the abdominal fossa here. Then we identify the branch of the radial nerve which goes to the long head of tricep and uses as a donor. To the axillary nerve to reinnervate the deltoid. So this is the surgical exposure. This is the proximal, that is the skull. This is the deltoid. This is the axillary nerve. This is teres minor, teres major. This is the radial nerve, and this is the branch coming from the radial nerve to the long head of tricep. This is the lateral head of tricep. So we took the branch from the going to the long head of tricep, and then we connect it to the axillary nerve. You can see these are the branches, deltoid. And this is the immediate post-op evaluation. You can see here that we use the donor from the spinal sensory nerve, and we see that the trapezius is still working because we have not taken the whole spinal sensory nerve. So the proximal branch is going to the proximal trapezius is still working. So we're not causing patient more problems per se. Me. And then this is evaluation of the 10 intrinsic. So wrist flexor is still good. Flexor pollicis longus slightly weakened. We can see it's still flexing, but it's still weakened. Cannot make an O sign. It's weak. With the functions of the AIN or the anterior interossei nerve, which is one of the branches of the median nerve. So other hand intrinsic, which is the ulnar intrinsic nerve, also still preserved. And 2 months post-op, the FPL is already recovered. So again, it's not a big issue. This is the patient 6 months after the surgery. So we can see that the bicep is starting to recover, still struggling to flex his elbow, but you can see the elbow flexion there. So it's grade 3 elbow flexion. Okay. Then in 9 months, you can see that the bicep is getting stronger. So it's having an easier time to flex his elbow. In 9 months, the deltoid and the supraintestinal is starting to recover. You can see probably about 45 degrees of 30 to 45 degrees of elbow flexion. Shoulder flexion. And this is the patient in 30 months post-op. You can see the bicep is getting stronger here. Easier for him to flex the elbow. Arm towards his arm. Up, above the head. And about 45 degrees of shoulder abduction. And the patient just recently came for a. Oh, okay, wait, this one. This one just wants to show that the donor nerve is still functioning well. Spinal sensory nerve here, the EC is still functioning. This is the radial nerve. Elbow extension is still very strong. Wrist flexion, also good. AIN, flexor pollicis longus, and FBB.
Dr. Ferry, the time is 2 minutes
Yes.
left.
Okay, almost done. Okay. Scapular ring is still present. This is not interpreted. This is expected from preganglion C56 F3, and it's not prepared because that's not the primary target. And this is the patient. He just recently came 2 weeks ago. So this is 8 years after the surgery. He has another surgery. He came to me because he has another surgery. He had a humeral fracture from a fall. So he just want to check if it's okay. So elbow flexion. Flexion was with more reform. Forward flexion. Shoulder abduction about 90 degrees. And also external rotation, which shows the functions of the spine. Okay, so the take-home messages is the clock start ticking at the time of injury. So in cases you need early surgery, you have to do it early. But for cases who require observation, we should do or we should observe the patient to see whether there's a spontaneous recovery or not, or to see more clearly the presentation on the clinical picture of the patient, whether it's a high flex injury or upper flex injury or low flex injury. So early recognition, investigation, and if necessary, early interventions are essential to maximize the patient's outcome. And nerve transfer is a viable option. It's very viable in patients with upper flex injury, especially patients with preganglionic injury. And with proper management, the result of surgery can be very rewarding. Very rewarding for patients, in particular for upper flex injury. As you can see from the case that I have shown you, patients coming from grade 0 elbow flexion and shoulder flexion now achieving almost normal function. I think that should be all from me. Thank you.
Okay. Next presentation. So, because in Indonesia, I think the peripheral nerve surgeon is few. Maybe the complete trial just only maybe Dr. Ferry. I guess I know. There's no other. So I think this is important for the young neurosurgeon in Indonesia to improve your capability of the peripheral nerve, because this is still not developed comparing with the other branch like tumor, vascular, spine, for example. So for the next is a discussion. We have one or two questions. Maybe the first chance is panelists. Is there any comment or question from the panelists, please? Professor Senal, Dr. David, Dr. Agus.
Yes, I am. Hello?
Dr. Yuris?
Yes. Yes.
Yes.
Okay.
My presentation, Dr. Ferry Sanjaya.
Yeah.
It's nice and nice results for the surgery. Anyway, I have a question about, do you have any criteria for the patients mentioned that you can predict the outcome of the patient after the surgery at the peripheral nerve operation? Do you have any prediction criteria for the good outcome of the patient?
Please, Dr. Ferry.
Sorry, I didn't get that clearly. Maybe you can just type it in the Q&A maybe, or maybe the third guess. Did you get that?
Yeah, is there any criteria for the good result from the patient?
Okay, so basically to achieve good results.
Yes.
Okay, so we know that the chance of nerve recovery is very time dependent. So time is very essential. So try to do the surgery as early as possible. as early as possible doesn't mean that once you have or you see patient with let's say with motor vehicle accident and then you do the surgery on the next week or next 2 weeks. So basically you have to understand whether the injury is it a hand plexus injury, is it a upper plexus injury or lower plexus injury, and is this a pre-ganglionic injury or is this a post-ganglionic injury? So basically the question is the patient going to recover by himself or not? If we know that the patient is not going to recover by himself, of course we need to intervene. And when do you need to intervene? What strategy you need to do? So in general, upper plexus injury is the best subset of patients with brachial plexus injury to get the most functional result. The reason for that is because the locations of the paralyzed muscle is proximal to the location of the injury. The time needed for recovery is not too long. If we compare it to the lower plexus injury, lower plexus is one of the, of course, the worst is hand plexus injury. So basically, the most difficult part is trying to to achieve the recovery or functions of the hand. It's very hard because the locations of the muscle involved is very long from the brachial plexus. It will take a very long time for the nerve to uh, to get to the muscle. Take for example, if we try to renervate the hand intrinsic in patients with lower plexus injury, if we do a proximal nerve graft and the muscle that we target is located at the, let's say, on the thenar muscle or the hypothenar muscle, the distance from the injury to the muscle itself probably about 75 centimeters. So 75 centimeters, 75 and 50 milli, 75 and 50 days, which approximately 2 years. So it's a very long time. And the functions of the muscle itself is very complex. We compare it to the deltoid or the biceps. It's basically the functions of the muscle is basic. It's just flexion and extension. This is to flex or extend the elbow. And the locations of the muscle to the injury is very close. Even if you do a nerve graft at the supraclavicular part of the flexion, probably the distance is probably about 35 centimeters. So 300 millimeters, approximately about 300 days. So the time for the nerve to reach the muscle is very important. That's why the result of patients with lower plexus injury is not very good to return the functions of the hand. And for hand plexus injuries, of course, it's the worst variations of brachial plexus injury because there's no remnant of functions of the brachial plexus. You cannot use the component of the plexus to renervate the affected nerve. So you have to use nerve from the extraplexal. So use the intercostal nerve, use the spinal accessory nerve. You only have so not a lot of nerve as a donor. So you have to focus your reinnervations to the muscle or the function that you want to gain the most, which is one is elbow flexion, and second is the shoulder abduction. So there's no nerve left for, let's say, for wrist flexion or finger flexion. So in general, best case is upper plexus injury. You can do the injury. You can do the treatment prior to 6 months. That's the best case, I think.
Okay.
Okay, thank you, Dr. Ferry.
Okay. Thank you, Dr. Ferry. Thank you, Dr. Yuris, because the time is limit, and we have to take a rest for 1 hour, and we start the next session in 4 o'clock. So thank you, Dr. Ferry, and all speakers,
Thank you.
the panelists. We close this session, and I back to the Dr. Dira, please.
Okay. Okay. Thank you for your attention, and ladies and gentlemen, that will be for the first session. And now we will take a break for an hour. Well, actually half an hour. We will start the second session at 4 p.m. and see you in the second session. Thank you.
Pak Yoris? Sudah dicoba itunya, videonya? Lagi?
Belum. Coba lagi ya.
Itu panggil coba Mbak Nina, coba.
Ya, lagi sudah mau coba dulu, silakan. Udah bolanya udah dikasih.
Mudah-mudahan bisa. Internetnya masih agak kacau soalnya. Biasa. Hanya kemana aku tanya internet juga. Problem. Bisa nggak DP-nya?
Kelihatan bro, putus-putus sedikit tapi jalan, play.
Play ya. Oke.
Oke, mulai ya. Oke. Halo, okay. Good evening, everyone. Welcome to the second session of the functional satellite. The second session will also be led again by Dr. Made Agus Mahendra Ingas. We invite Dr. Made Ingas to start the second session. Please, Doctor.
Okay, thank you, Dr. Gira. We entering to the second session. We have 3 young neurosurgeons as a speaker with a very interesting presentation, and we have this discussion in each speaker. The first is Dr. Yuris Bahtiar, PPS PhD, with the topic is basic concept of presurgical evaluation on epilepsy surgery. 20 minutes for presentation and 10 minutes for discussion. Please, Dr. Yuris, and yours.
Okay, thank you, moderator, analyst, and good evening, panelists and every participants. I would like to discuss more basic specific information in epilepsy surgery because it's very important for the young surgeon, neurosurgeon, especially to the how to diagnose the epilepsy properly. So it's not like just see seizures only, but you have to see the symptoms and all of the symptoms inside it. So before that, I would like to thank with Professor Simon Mutakin and team because of them, we can produce a lot of paper, and this is the new paper of us. We have three papers, which is in epilepsy surgery and also in all occupations that we already surgery for the more than 1 decade. So we have 700 cases already, and we have a lot of data update and try to publish one by one. So how about the epilepsy? Epilepsy is a group of neurological disorders characterized by epileptic seizures. But epileptic seizures are episodes that can vary from brief and very undetectable periods to long periods of vigorous shaking. So epilepsy is not like, it's just not like shaking, but we have to think about the episodes that can vary from each syndrome, and you have to diagnose properly to have a good area of epileptogenesis. And epilepsy is disease that brain defined by any of the following conditions. We know that at least 2 provoked of reflex seizures occur in 22 hours apart, and 1 unprovoked of reflex seizures is probability of further seizures similar to the general recurrence with up to 2 unprovoked seizures and diagnosis of an epilepsy. So, what is different between epilepsy and seizures? Because seizures is like sometimes it's provoked or sometimes it's not. You can see maybe you have a trauma and become a seizure, but epilepsy is at least 2 unprovoked seizures that you can have and diagnose epilepsy or not. And seizures with epilepsy, you can easily understand about the seizure event and the epileptic disease associated with spontaneously occurring seizures. So not only or not all of the seizures are epilepsy, but all epilepsy are seizures. So you have to differently. And the definition of the epilepsy from Elaine, some of them, and NC Junior, where the epilepsy is disorder of the brain characterized by an ongoing predisposition to generate epileptic seizures and by the neurobiological problems, cognitive, physiological problems, social consequence of this condition. And the problem is not the seizures only. The problem is not which part of the brain have abnormality, but you have to understand the concept of epilepsy that the diagnosis is not like that easy, but maybe you can make it easy after you understand all the epilepsy. So for this epilepsy definition, disorders have 2 or more unprovoked seizures. That's the epilepsy, person epilepsy. But concept is easy to apply, not too many, but some people people are treated if they have epilepsy or what. A person that never outgrows epilepsy can have any epilepsy syndrome. Sometimes a benign rheumatic epilepsy is like epilepsy, but not epilepsy. Those reporting of rebirth cases are not defined as epilepsy. So you have to understand that epilepsy sometimes is not epilepsy because it is not a benign rheumatic epilepsy. So the Eli have a classification of diseases type of 2017. They divide into three groups of epilepsy phases. One is of focal onset. It means that it came from one focal area in the brain, and the second is generalized onset. And sometimes you can even know that this is unknown onset or unclassified. And in the focal onset, you have to believe that this is aware of impairment. So, is it aware or impaired? So, a previous Eli classification is divided into complex and non-complex, simple and personal. But no, in 2017, they changed the classification. So they divide into focal onset, generalized onset, and unknown onset. So the problem is how to diagnose this focal onset. In which if you can find the focal onset, it means that this is maybe a good candidate for the surgical epilepsy because you have a motor onset or not motor onset. So talking about the seizure, talking about the epilepsy, you have to do if you have a seizure sign, then you have to think about diagnosis. It means that the diagnosis is genetic, structural, metabolic, immune, infection, and unknown. Or maybe the epilepsy is caused by seizures like that. So after this, you can find into focal or three groups, scientific. Then you can find the epilepsy syndrome. Then you have to find the epilepsy of that, and this is like a circle. So you have to think the epilepsy syndrome itself. But the important is you have to diagnose with how about the comorbidity itself. Epilepsy is not a disease only, but epilepsy has a social impact that you have to understand. So the epilepsy, is very complex syndrome, but who is the candidate for that? So we are agree about the epilepsy surgery may be considered by anyone who treated with cars despite appropriate treatment. So it means that we already have one, at least two, or another 2 years. And then the seizure is not recurrent. The seizure is recurrent. So it means that intractable epilepsy. So you have to find why the epilepsy itself is intractable or not. So factor for choosing candidate for epilepsy is the type of epilepsy, the frequency, severity of the seizure, side effect of the medicine, the risk of accidents, the impact of the patient's quality of life, the functional expectation and the deliverance of the patient, and it's difficult to establish using criteria. So you have to think the epilepsy, you have to think comorbidity. Nevertheless, the decision is usually based on 2 factors. First, the response to the treatment. Whether patient is resistant to the treatment needed is the candidate for epilepsy. And the type of epilepsy. Whether patient have one of surgical remediable surgery is the candidate for the epilepsy surgery. So early surgery is recommended if there is excessive delay, is considering surgery is not acceptable. So if you found if you're sure that this candidate for epilepsy, you cannot delay that. You cannot delay the surgery because when you delay more and more, the quality of life after the surgery is slightly different when you do the surgery in the beginning of life. So as soon as possible, we can diagnose, and you show that this is epilepsy, then you have to do surgery. So, for the study for epilepsy, that I make 4-3 solution that persistent seizures is not appropriate primary treatment. You see at least 2 drugs approach the seizures but adequate sleep as it complete, and impairment of quality of life due to unpleasant seizures. This is 3 and in our team, we have 3 phases of the epilepsy surgery. So phase 1, we have to know the high history taking, physical examination, semiology, ultrasound, MRI, and this is we know how to differ. This is a focal onset or generalized onset, or maybe before it can say that this complex portion or focus of season. So, and then the phase 3, and you know, if you're sure that this is phase 1 from the phase 2, and phase 1 and phase 2 are clinical or physical surgery, then you can go to the phase 3 like surgery itself. So, localization and boundaries for epileptogenic zone, that is true, is the analysis of the certain semiology. So, semiology is more important. And ectophysiological report, then functional testing, then neuroimaging technique, then neurophysiological assessment. This diagnose method to find different cortical zone. So the cortical zone that I mean is that I say that it's about the initial zone, ictal onset zone, epileptogenic lesions, symptomatic genital zone, functional genital zone, epileptogenic zone. And you know this is a brain, then you have to understand about where is the receptive zone, it's EEG abnormal zone. Where is the ictal onset zone? Onset zone. Where is actually the epileptogenic lesion itself? And where is the symptomogenic zone and functional genital zone? Maybe it's like a boundary. So you have to understand about it, and you cannot just taking the epileptogenic lesion only without thinking about the ictal onset zone, or maybe you're not thinking about the irritable zone, or maybe you cannot think about the semiology. You can find the symptomatic zone, but this is not actually epileptic. So, the physical evaluation, most important is history of physical exam. Yeah? Most important. So, from the history of physical exam, you know the lateral and lateral and the semiology. In semiology, what commonly do is you can see the aura. Aura is one of the important lateral enzymes. You can find this aura, you know the sensory aura. You have a pain of 89 lateral, and you feel visual aura, which may be 100 lateral symptomatic zone, or maybe a motor patient, chronic activity, and maybe you can find the figure of 4 that one hand is extended. It means that when you can find like this figure of 4, maybe you can find that this came from the contralateral side. It means that you can find the extended left, then the epileptic lesions can be found from the right side. Okay? And maybe you can find the automatism at 100 non-dominant, and ictal splitting, and maybe ictal vomiting, and it's a lot of review about this. Maybe you can read. And about the language, and most important thing is post-ictal motivation. Post-ictal, when you see the post-ictal and then the patients like this, maybe it's this ipsilateral epsilon. So the right hand nice wrapping, which means that the right hand is in a selected hand. So, I'm sorry. So, this is one figure. Maybe you can see. This is, maybe you cannot find this in the physics or not, but you just feel like during the game and they feel like comfort, yeah, uncomfortable in stomach. Yeah? This is season. This is aura. This is aura. This is commonly seen before the season, like a general season. Yeah. On the other hand, maybe you can find like blank, confusion like this. Is it season? Yes, of course this is season. When you try to see, this is confusion like this. This is exact confusion. This means that maybe you can find where is the epileptogenic zone in this patient. Yeah, they don't understand what she did during the whole work. But unfortunately, after the season opens, yeah, after the openness finish, she directly understand and don't know what she did. Yeah, this is season. Then maybe you can find, okay, this finish. Maybe this finish. Yeah, this finish. Finish season. And maybe you can see this kind of season. If patients with hypocamp sclerosis, with automatism and dystonia. So no general season. Only like this. Yeah. Yeah. It's like vomiting. Yeah. Like a vomiting and do like automatic hand like that. And you can see in the MRI, you can find the right hypocamp. After the surgery, after we confirm this is came from the right hypocamp, this patient not recovery. The epilepsy is cured. And another case is like this. It's quite difficult to it's complex, but you can see that it's going close to, and maybe you can find a patient of the head pressure to the left. Okay. That patient to the left. Yeah, patient to the left. And you can find figure of 4. Figure of 4. This figure of 4. Yeah, this is figure of 4. Left hand extension and right hand section is mean that shifts came from the right temporal. Yeah? But this is already general sign. So this general. So the video is important. Disseminated during the eCall is important. Not the generalized eCall, but very generalized eCall. It means that came from aura. It came from the aura, and if you can have a good picture of that, maybe you can do the diagnosis properly. And maybe this is a complex one. This surgery was we do after the surgery, yeah, after the diagnosis, we can have a nodular hypertrophy, yeah, nodular hypertrophy on the side, right side. Yeah, the surgery is like pedaling. It's like a common terminology of frontal lobe. Yeah, pedaling. Okay, let's like this. And we do the ECOG during the operation. We do the ECOG during the operation, and we can find the epileptogenic zone in this area and from outside. Okay? And this is also one of the ongoing process of the season. It's starting for left patient of the face. Left patient. It's made that it's from going from the right side. The application is the left side. It's like just only like a portion. But now, after 2 or 3 months, the season terminology change like this. So, of course, this is from the right side. This is figure of the right side. So, contralateral of the extended hand. This from the right side. So you can see here, yeah, this pressure cortex of the frontal lobe here. Yeah, this pressure cortex of the frontal lobe. Can you see my presentation? I hope I have.
Yes. Yes, Dr. Yuris.
Okay. Okay. Thank you. So, and maybe no symptoms like this. Like a drop attack. Okay, let's drop. Or maybe during the in background. We're playing scope. Okay. So just for it. So we do the cortical, we call focus corticotomy, and here, very well. So after that, after the aura, the clinical terminology, and that of things just depend on different appreciation of cortical phase focus. Yeah? It depends on maybe temporal lobes or frontal lobes or occipital lobes or parietal lobe and so on. Yeah? It depends on that. So we have to confirm, we have to read about the semiology. But semiology is more important. And how to read semiology? You can have the semiology after you see the seizures. Nowadays, you can study information about the seizures. Yeah? You can ask the patient to take a picture, take a video of patient with their seizure. So it's important. So limited semiology is semi-subjective, but nowadays it's not subjective. But beforehand, before we have an area of smartphone, they don't have a video. Maybe the parents cannot tell very precisely, very good in the semiology. Maybe they say, oh, this is the patient have a right patient of the face in the seizures. And the mother said, no, this is math. So it's subjective. But nowadays, no, you can do with your video recording. Yeah? And CCSMO is the manifestation of activation of the symptomatogenic zone. To be careful. Sometimes physiotherapy is not epileptogenic zone. It's just manifestation of activation of the symptomatogenic zone. CCSMO does not always permit differentiation of focal or general epilepsy. Again, it's not always focal, but sometimes it's general epilepsy. Yeah. So then we have to know the EEG because EEG is more important. With EEG, you can see the onset of the epilepsy. Where is the zone, where is the epileptic genetic zone, the area of cortex to be special with the EEG. Yeah? So historical concept of epileptogenic zone is based on has a flow from the recording of the interictal spike, both in sub-EEG and electrocardiogram. In modern times, the determination of epileptic zones demands a sophisticated combination of neurophysiological and neuroimaging tools. So beforehand, before you know the areas of neuroimaging and neurophysiological and maybe neurofunctional imaging, we use the EEG for detection of epileptogenic zones. But the epilepsy surgery, the EEG itself sometimes is not enough. It has to compare with the neuroimaging. So the precise localization and definition of the extent of epileptogenic zone or EEG is that cannot be delineated directly. So diagnosis tool is the scenario analysis, neurophysiological technique, functional testing, structure, functional neuroimaging, and after you can go to define the quality of EEG. So the important EEG recording, using the bank EEG, ICTAL EEG recording is very important because the not the ICTAL onset ICTAL EEG in inter-ICTAL EEG you cannot have a precise epileptogenic zone, but in inter-ICTAL EEG or standard EEG like not the 24-hour EEG, then you can find the receptive zone, but not really proper epileptogenic zone. But in ICTAL recording, ICTAL zone, it's important to use the ICTAL EEG recording to pencil through positive. Why? Because lesionectomy, lobectomy, multifacetomy, hemispherectomy, thoracotomy, vaginal stimulation depend on the ICTAL EEG recording. Why EEG recording? Yeah? Just only the intuitive zone. Only intuitive zone. Yeah? With inter-ICTAL EEG, you can find only the intuitive zone. Okay. So sometimes you need to catch the ICTAL EEG recording, but sometimes you don't need. If the seizure syndrome or the epileptic syndromes are very classical, and you can found in imaging, this is correlated and very correlated, close correlated with imaging abnormalities. Maybe you can go directly to the surgeon, like a simple hypocombustion. Maybe you can go directly to the surgeon. But more the complex one, maybe you cannot do that. You have to go to the ICTAL EEG recording. So in scope EEG, sometimes you can find neutralizing value. So it's quite difficult sometimes. So you have to learn how to read the EEG properly. Next, after that, after the EEG, maybe you can go to the imaging. Imaging. After the imaging, imaging is very important. So you can use the MRI, or maybe you can use MRI. Before we use the 3 Tesla MRI, sometimes we use 2000 and before 1990, for dynamic starting with 0.5 Tesla MRI. You can use that for diagnosis. But nowadays, maybe 1.5 Tesla you can use diagnosis again. Epilepsy, epilepsy is zoned by imaging abnormality. Yeah. So this is the right hypothalamus sclerotic. Yeah. This area, and this is the left facial temporal hypothalamus sclerotic. This is T1. This is T2. This is slightly different size of hippocampus. Yeah, on the right side. And after that, maybe sometimes you need use the functional imaging like PET, or maybe for registration with MRI. But this is not really compulsory if you found already found the abnormalities in the MRI, standard MRI. Or maybe you can use the Syscom PET with MRI quantification. Also, this is not really important if you already found the appropriate during this standard MRI. So maybe you can use functional MRI like a very advanced MRI. Maybe you can use MEG and for registrations with MRI, and using that you can find the epileptic zones more precisely. And maybe another thing. But testing for cervical candidate depends on one. This will take from testing and researching with identification. So you have to understand about the before the surgery functionally. So you have to inform the physiologist. And after the surgery, the physiologist is damaged. Okay? And maybe you can use the WADA test for the functional. And during the phase 2 monitoring, maybe you can use the supraorbital electrode and functional EEG. Maybe you can use and cortical mapping. After the fase 2 EEG monitoring.
Excuse me, Dr. Joris, three minutes left.
Okay. So after that, after the diagnosis, please do not forget the physiological evaluation of cervical candidate. It's very important. Yeah, very important. So this is like a syndrome. Not only you can going directly to the surgery, but you can thinking about the physiological effect of the surgery. So conclusion is we need to pass one investigation and directly going to surgery, or maybe you can going to the phase 2 intracranial EEG examination, and after that going to the surgery. So when you found the concordance between semiology fixed with EEG and with MRI and with imaging, you can go to the surgery, the concordance. But be careful if you cannot find the concordance or discordance when you focus to an area you have to go to the intracanal imaging. I think that's this our my presentation today, and the conclusion is lateral designs can provide information about the correct hemisphere and its onset in about 75% of the patients. Consistent recognition of the sign is achieved only by strict adherence to established definitions. Contralateral sign, example, early version, dystonic closure, eye face definitions have high lateralizing value up to 100%, and ipsilateral sign show a correct lateralizing accuracy up to 90%, and please careful attention to install and documentation of the safety terminology, which enable intensive evaluation of medically refractory patients with disabilities. Thank you very much.
Thank you very much, Dr. Yuris. This is a complete nice presentation from the young neurosurgeon consultant in Semarang. It's good. Well, and then we maybe have 3 or 5 minutes for discussion. And the first step maybe a panelist or another speaker maybe have a question or comment, please. Okay, if there are no question yet, so I want to ask about
Comment, Dokter. Boleh, Dr. Rigas.
Silakan, Dr. Heri.
Yeah, thank you, Dr. Yuris, for excellent presentation. Actually, any surgeons who are interested in epilepsy surgery, he or she must be able to know the semiology like this. This is what Prof. Zainal, Dr. Tohar asked me to learn more about semiology, because by knowing this semiology, we can at least 75%, especially for temporal lobe epilepsy. This is very useful for us to start epilepsy surgery. And one thing that if we want to start epilepsy, start with the most simplest case. Actually, there is no simple in epilepsy, but we must start with temporal lobe epilepsy, like what Prof always said to us. So this is very good, very useful, and hope that many neurosurgeons will be interested in this kind of epilepsy surgery. Thank you, Dr. Yuris.
But the more important thing, not only for the surgeon, we have to understand about the coordination with other specialists, like neurologists, like radiologists, like psychiatrists. So this is more important. So it's like to make a complete and team, physical team. And if you cannot do that, it's impossible, I think. But that's very important, I think.
Yes.
Yeah, that's great. Knowing the EEG, knowing ictal video EEG, knowing MRI protocol, knowing PET scan, SPECT scan, and especially MEG scan is also important. But at least to give encouragement to young neurosurgeons to learn, first learn about semiology, and then after that, learn about video EEG, learn about neuroimaging and all.
Yes.
Okay, thank you, Dr. Heri. Dr. Yuris, is there any question? Maybe
from
Professor Zainal, please.
Okay. Jadi for those who are willing to start epilepsy surgery, what Dr. Heri said, learning about the concept, the semiology and everything, not the technical. For technical surgical technique, if you have the case, you may invite any of us. You may invite Dr. Yuris, Dr. Heri, Dr. Tohar, or myself to come to your place and join your surgery, for learning about the technique. But the most important is the concept, and then we are willing to teach you the concept too. So For learning the concept, it takes time. It takes time to work in the team. Yeah. It is impossible to work for epilepsy surgery alone. And as Dr. Harry said, with the simple temporal lobe cases, why we call it simple? Because the result is the best. The result of the surgery for temporal lobe, simple temporal lobe with clear-cut hippocampal sclerosis will have the best result. We need to show this result to the society, to the people, to other doctors. Yeah, otherwise you will not get more patients. Yeah, you need patients from other doctors, especially neurologists. So we have to work together with them. That's my advice. Okay, thank you.
Thank you, Prof. Zainal. This is an important quote for us as a young neurosurgeon and to develop the epilepsy surgery in our each hospital. So because of the time is limit and we have to move to another speaker, I invite Dr. Muhammad Agus Aulia. He from the Center Army Hospital in Jakarta with speak of stereotactic functional brain lesioning as a choice of treatment for Parkinson's disease in the PGS era. Okay, having your time, Dr. Agus Aulia. Excuse me, I'm sorry because of we have to present the sponsor first before Dr. Agus Aulia present his PowerPoint. Bu Nina, please. The sponsor session, please. Halo. Nanti saya telepon, saya masih lagi webinarnya. Ada penting nggak? Oke. Bentar ya. Ya, nanti ada. We waiting for Dr. Agus presentation because we have a problem with the laptop. Waiting for a moment. So during we waiting, can I open the discussion with Dr. Yuris? Dr. Yuris?
Yes, please.
Yeah. Usually we have to know. I want to ask about the dominant side of epilepsy surgery. We have to find out the dominant lesion, for example. So, do you usually use DSA or angiography for functional tests?
Not really.
Mm.
Yeah. Sometimes we only have use the right-handed questionnaire, or maybe you can ask which part that they usually use his hand in every day. So in work they use on the right hand. Maybe you can use that for the assumption that you can do it from the left side. But for the simple procedure like temporal lobotomy, we do not need that much because we didn't attach the broca, or we didn't attach the limit area for the surgery. So I think we don't need that. So starting from the simple one, as Professor Mutaki said, so that we can go to the further complex, and maybe after that we use the WADA test. We already do the WADA test for several times, and the result is very nice.
Okay. Okay. Thank you, Dr. Yuris. I think Dr. Agus Alias is ready to present his presentation. Okay.
Thank you, Dr. Ingas. Good evening, Professor and other panelists. Today I'm going to present my topic about syntactic brain lesioning as choice of therapy for Parkinson's disease in BPJS era. This might be an answer to previous question by Professor Zainal Mutakin. Professor was asked, can brain lesioning replace the DBS for Parkinson's disease? And this is also has a relation to the previous Professor Taira said that he somehow has already abandoned the DBS, and maybe this is the era of brain lesioning. We will see. Maybe my presentation can answer that. I would like to start with how big the Parkinson's disease problem in Indonesia. We should know how big the Parkinson's disease patient, how big the numbers in all over the world or in Indonesia, and how Parkinson's disease patients is become a burden socio-economically for the patient, for the family, for the community, for the even for the nations. And also, this also become problems in Indonesia. It is a chronic progressive disease. It is a long-term disease. It needs long maintenance of pharmacotherapy, long of seeing a doctors, and so on and so on. This is the number from Global Burden Disease Study in 2016. There is an increase, significant increase of Parkinson's disease patients from 2.5 million in 1990 to 6.1 million in 2016. Why? Because of course there's an increasing number of older people. As we know that this Parkinson's disease is dominated by the older people, more than 60 years old. And globally, the deaths in 2016 about 200,000, and that means an increase about 20%, and prevalence is also increasing about 20%, and disability is also increased in 22%. So there's an increase. And I also see from the economic view that this Parkinson disease is quite costly. There is more money to spend on to treat this patient. Is this study from the American Levin Group about economic burden on treating Parkinson disease? There are some study from 2003, 2007, and until 2017. We can see because there is increase in prevalence. Also, the cost is also increasing from $10,000 per capita. It's increasing to $24,000. It is a direct cost. It is a cost for the pharmacology therapy, for the doctors, for the surgery, and not only that, it is all for this indirect and non-medical cost. This is economic expensive for Parkinson's disease in Singapore. It's also pretty much the same with the world, and annual cost for PD pension there is about 151,000 per patient, and it is said that 50% from this cost is for pharmacotherapy. Not to mention DBS implant. We know that DBS implant is pretty much expensive, about 300 to 500,000. So can Indonesian health system cover this DBS? Let's see. How about in Indonesia? I don't find any national data about, cannot find it about the number of Parkinson patients in Indonesia, but we can estimate there's estimated prevalence or incidence by looking literature in Asia. This prevalence about 50 per 100,000 or about 30 to 50 per 100,000, and the incidence about 8 per 100,000. So maybe that's picture the number in Indonesia. Another problem is, it's not a problem, it is in fact a good effect that aging population in Indonesia is increasing. That means there's an increase in economic and socio-demographic. We found that there's increasing numbers of people aged above 60 years old. It is compared to 1971. It's pretty much significant. It is said that from 5 decades, there's an increase about 2 times fold. What does this mean? This means there's increasing number of aging population. There will be increasing of Parkinson's disease numbers with disability, and it will become a burden for Indonesian health system and socio-economic. What can we do as a neurosurgeon in Indonesia? Of course, there's a challenge of Parkinson's disease surgery in Indonesia. Treatment of Parkinson's disease mainly by pharmacotherapy, levodopa, and surgery is part of PD management. It can be DBS or brain lesioning, but as we all know that DBS is this is DBS era. Brain lesioning has a long history, but today, like Professor Chaira said on the morning lecture, it starts to be abandoned by the neurosurgeon in other countries. So what we face here is there's little or only a few neurosurgery centers performing surgery for Parkinson's disease, and it is localized or centration in Java Island, and then only few functional neurosurgeons do this surgery, and also the tools, it is not well distributed. And this is what I'm going to discuss now. It's the availability and feasibility of the implant. DBS is costly and it is not covered by Indonesian Universal Health Coverage or BPJS. So if DBS is not feasible or it is not well ready or we cannot do DBS, then what can we do? The answer or the next reasonable step is doing brain lesioning for PD patient who meets the surgical criteria. I would like to give picture about brain lesioning surgery for Parkinson's disease. Interestingly, that this brain lesioning has what do you say? It has increased and decline, and there's an era where it is renaissance again, and there's an era where it is start to be abandoned. It started at 1942, Spidels and Wyss doing palliatomy for Huntington chorea, followed by another neurosurgeon, Hassler Richard, thalamotomy for tremor, and then Lexel, palliatomy, and then after that, there are increasing number of brain lesioning all over the world by Narabayasi, Oye, Cooper, and etc. But not until the invention of levodopa in 1968, levodopa was invented, and then it is widely used and as a main therapy for Parkinson's disease. Then there's declining of brain lesioning surgery. But and then they found that there's limited benefit of levodopa. Levodopa has side effects. And then there's, because of disease progression, it is not optimal to improve the symptoms. Then the brain lesioning start to increase again. There's a renaissance, and it is in the mid-80s when Lauri Laitinen in Sweden and Umeå start doing lidotomy or thalamotomy. And then in 87. When Benabit used DBS to treat Parkinson's disease, and then it starts to decline again. And DBS, almost every part of the world, all the neurosurgeons using DBS. And if we Googling literature research in at that time, around 2000 until now, surgery for Parkinson's disease is DBS. It's dominated by DBS than brain lesioning. So why is it declining? Is it worse than DBS? How's the outcome? If we compare DBS from the brain lesioning, is it worse, the lesioning? I would like to show you what we're doing. What is brain lesioning exactly? Brain lesioning means we lesion, we make some cells dead. It is a functional lesioning in brain structures, which is responsible in causing movement disorder. And there's a few target in the brain structures, like globus pallidus internus, and then the thalamus. We can choose about ventrooral, ventral intermedia, and there is subthalamic nuclei, there is cauda zona incerta, there is like Professor Tyler said this morning, there's a pallidothalamic tract. But most target lesioning is this globus pallidus internus and the thalamus. How come by lesioning, by making the depth of the cells in pallidum or in other basal ganglia can improve the Parkinson system? If we understand this, then we can see how that happens. in this left picture, I show you that this is a pathway. This is a movement system involving basal ganglia. We can see this is the globus pallidus. I'm sorry. This is the subthalamic nuclei. This is the striatum. This is thalamic. This is all a system. This is system based on inhibition and stimulation. We can see that this is this green arrow. This is the stimulation, giving stimulation, and the red arrow means inhibitions. And all of this making our movement is smooth. And when there's a Parkinson disease, that means the defect in nigra compacta or substantia nigra. There is less dopamine produced. This means we can see there's a little thin dashed line. That means there's a decrease of stimulating or inhibition in this part. That causes the system is imbalanced. There is a shifting. And this imbalance eventually come to dysfunctional motor in Parkinsonism. There's a clinical sign. We can see the rigidity, we can see the tremor, we can see the bradykinesia. And what happens if we lesion the GPI? We can see this. This is the internal GPI, and this is the electrode needles. And when we do the lesioning here, meaning that we decrease the inhibitions at this part, inhibition to the thalamic nuclei, and in the end, or eventually, this will reverse to the near normal balance of movement system, and eventually it is shown as improvement in rigidity or in tremor or in bradykinesia. This is what we do. This is what we lesioning. This is the rationale. We can see this is the frontal cortex. This is the ganglia basal that involved in movement. Thalami. This is the global pallidus, in externus, internus, and it is subthalamic nuclei. And there is other nuclei here. And then when we do the lesioning here, we call it thalamotomy. We do the lesioning here and the subthalamic, we call this subthalamotomy. Here is pallidotomy. Here the PTT is the pallidothalamic tract. This is pallidothalamic tractotomy, and this cerebral tractotomy. If we can understand this, when we have the rationale why we do the brain lesioning, I want to emphasize that brain lesioning for Parkinson disease, it is not curing the disease. The Parkinson itself, it is still happen. It is still progressive. It is still chronically progressive. But the brain lesioning, it can improving the rigidity. It can improve the tremor or the bradykinesia. Somehow it can reducing the dopa-induced dyskinesia. Also the motor fluctuation, the on-off time of the patient, and then in some cases the dosage of the levodopa can be reduced. In other words, even though it is not curing the disease, but it can improve the quality of life. That is our goal or our aim. So is it how is the evidence of brain lesioning for PD? Is it worse than deep brain stimulation? Then we have to see the outcome numbers. We have to see the UPDR score, the Unified Parkinson Disease Rating Scale. It is an instrument widely used and standardized use to see the outcome of the therapy for Parkinson disease. And how is the complication rate, and how is the brain lesioning today? Is it different from the brain lesioning 50 years ago? This is the evidence-based. I take it from the Marwan Harid's literature in neurofunctional books that pallidotomy improves the UPDRS scale in on and off medication. It is improving the rigidity, dyskinesia, and on-off time. In his writing, he resumed about 10 studies from other neurosurgeons in different times, and it was a long follow-up until 24 months, and the shorter is 6 months. And all of the results show the reduction of the UPDRS score from 16%, and there's 35%. What this mean? What does this mean? Reduction of UPDRS score means there is improvement in rigidity, in maybe in dyskinesia, or the on-off time, or the motor fluctuation. It is our goal to reduce the UPDRS score. And another evidence show that pallidotomy improves motor fluctuation and severity of DOPA-induced dyskinesia. I take this study from Eskandar in Boston, Massachusetts. It was in static pallidotomy performed in patient with PD, and it was 2 years result. The result is pretty much the same with previous slide I showed you. There is a decrease or reduction of UPDRS score, and then total on time and levodopa-induced dyskinesia and contralateral tremor. There's improvement, and this is the evidence base made by Movement Disorder Society. There's a conclusion on surgery. We can see here in the first row, there's bilateral STN-DBS. This is STN-DBS. This is pallido DBS, and this is unilateral pallidotomy. And we can see the evidence here for treatment of motor complication. It's so efficacious with pallidotomy. The same efficacy with DBS STN, the same efficacy with DBS GPI efficacy, and clinically useful. And also we can see that with symptomatic adjunct to levodopa, it is efficacious. Also efficacious unilateral pallidotomy, the same as DBS STN and DBS GPI, efficacious and clinically useful. This is the evidence for thalamotomy. Thalamotomy can improve tremor in Parkinson's disease. After DBS era on 1998, not many publications about thalamotomy with radiofrequency. If we Googling searching thalamotomy radiofrequency for Parkinson's disease, there's not much study or literature we can find, and no publication we can find. But there is what you can say is there's a new quote and unquote new thalamotomy used with focus ultrasound. It is a new machine, a new toy. It is a new machine produced by Israel. They use the ultrasound energy to produce a lesion in the thalami, and it is MR guided. And since then, there's slightly a rising of thalamotomy literature again. Even the FDA on 2018 approved focus ultrasound thalamotomy for Parkinson's disease tremor dominant. Is this the rise of brain lesioning again? Maybe. So, is it safe? Is it brain lesioning safe? How is the complication rate? The surgery, the complication usually is lesion related. It can be transient. It can be permanent. What we do is make a lesion and if it is a permanent lesion. Related to the lesion, it can be dysarthria because injury or edema to the internal capsule. It can be limb weakness because injury to the also internal capsule, the paresthesia, injury to ventrocaudal thalamus, imbalance because injury or edema to ventrocaudal thalamus, visual field deficit because injury to optic tract when you do paleidotomy, cognitive decline, or even hemorrhagic. But like Professor Taira said this morning about that brain lesioning today is different from brain lesioning 50 years ago. Why? Because we have better imaging, we have better MRI, we have better tractography, we have intraoperative MRI in some center, in some neurosurgery center who do the movement disorder surgery. They use intraoperative MRI. And we have a better planning. We have improved stereotactic planning system, better stereotactic apparatus, better radio frequency generator, a better microelectrode recording, which all of this eventually make better result with lower complication. I want to show you a slice of stereotactic atlas by Hassler. This is usually what we're dealing with, the brain structure we're dealing with. This is the coronal section. This is, we can see this is the putamen, the pallidum. This is globus pallidus externis. This is globus pallidus internus. This is the place where we do the lesions. And then another place here is in the medial part. We can see the thalami. This is ventrooral thalami. This is also another place that we usually do the lesioning. This is, and also we can find the subthalamic nuclei. This is the place where do listening or DBS. And this is Forel fields. This is also another spot or another target to do listening. Now, if we understand this, then we can understand why there is why it can be side effects. We can see that this globus pallidus internus has a very close proximity to internal capsule that brings pyramidal tracts. So if you miss the target about 3 or 4 millimeters, then you can make a dysarthria or a limb weakness, and you can see also below this spot, this globus pallidus internus, there's a optic tract. So there's possibility for you to disturb this optic tract and causing visual field defect. So that's why in my institution in RSPAD we perform brain lesioning for Parkinson's disease. Of course, we choose or we select a good candidate for the surgery, because choosing or selecting a good candidate means a good result. We choose patient with diagnosed with Parkinson or Parkinsonism, diagnosed by a neurologist, and the patient must have a good response to levodopa agent, and patient usually come with motor fluctuations or dyskinesia. The symptoms may be rigidity or tremor dominant or both, and there should be no cognitive disturbance. We start performing lesioning at the end of 2017. I was having a fellowship with Professor Taira and also with my fellow Dr. Fahmi in Surabaya. We start 2017 brain lesioning. We have 32 brain lesioning, brain stereotactic functional procedures, 24 for PD and Parkinsonism, others for dystonia, essential tremor, chronic pain, cingulotomy, 14 paleidotomy, 10 thalamotomy, Patient age range from 43 to 72 years old. Duration of PD range from 3 years to 20 years old. 20 years. This is still a challenge for me. We start to collect data or completing data, but UPDR score, it is still in progress. And all of these patients offer DBS as a surgical option, but all are choosing brain lesioning for economic reasons. And almost all patients use BPJS. This is what I do. We planning and targeting. All patients underwent cerebral MRI before the surgery with stereotactic protocol. Planning, targeting 1 day before the surgery using Inomed planning system. We use Inomed Richard Mundinger stereotactic frame. And then on the day of the surgery, we do the CT scan with frame and fiducial box. On the day of the surgery, it will be awake surgery. We use no sedative agent. Of course, there's anesthesia monitoring the vital sign. We use local anesthesia, Pehacaine or lidocaine in incision site, one bore hole, unilateral brain lesioning, lesion using Postman generator. My electrode was 1.2 millimeter tip diameter with three non-insulated tip. I don't do microelectrode recording, but I always do micro stimulation, 0.5 to 3 volt, and then temporary lesion using 45 degrees for 60 seconds, and then permanent lesion using 70 degrees for 60 seconds. This is the frame that I use. We use the Richard Mundinger Inomed system, stereotactic. This is the Cosman generator. This is the electrode, the needle electrode with this is the insulated part, and then this is the non-insulated tip to bring the heat to transfer the heat here. It is about 1.2 diameter and 3 millimeter length of exposed tip. We target about 40 to 60 centimeter. 40 to 60 millimeter cubic lesion. This is, I want to show you a video about what we do. I don't know if there is a lag on my video. Please tell me if it is not functional properly. This is the day of the surgery. Usually I do a quick examination before the surgery. This is the patient with tremor on left and right side, and I plan to do the left side thalamiectomy to improve for the right side tremor. You can see that the foot is trembling more than the hands, and this is what he complained about the legs. It is more tremorous than the hands. And after that, we install the frame, the head frame. This is the head frame. This is the Inomed system. Yes. Pretty much the same with the previous lecture by Dr. Fahmi. We have to. This is the CT scan. CT scan with fiducial box. This is the image, and then we get the image of the CT scan with the fiducial box.
Sorry, Dr. Agus, the time is still.
Sorry. Okay. This is the surgery. We communicate with the patient. We do microstimulation. We see the effect of the stimulation. We see the effect of the lesioning. we can see here the tremor is completely gone compared to the other side. We haven't done this. It is still a tremor. We also check for whether if there is any other weakness of the limb or other dysarthria. We check for everything. This is, we can see the left side is there's no tremor, and there's also the right side is still tremor. This is the patient 1 day after the surgery. The tremor is reduced, improved. The right side we plan to another thalamiectomy. Very sorry. How much time I get? Hello. 2 minutes. Okay. Yeah, this is pretty much the same with the previous video. This is my case, 55 years, male with 12 years PD, rigidity dominant. He underwent left palaeotomy. There was improvement of rigidity in on and off period. I do UPDRS score in this patient. There is a significant reduction pre and post-op in off and on medication, and there were no post-op complications. This is the patient. He was a senior lecturer of ITB. This is the pre-op. We can see the patient cannot open wide his hand and his finger, and there's a difficulty in finger tapping. And after that, I sent a video showing the improvement of rigidity in left hands. In right hands, and we do another palaeotomy for the other side. This is again pretty much the same. 47 years old, PD tremor dominant, underwent stage bilateral thalamiectomy, good tremor control. There is side effects. He happened to have transient tingling sensation in lips and slightly imbalanced sensation, and we know that this is because the thalamus, the ventro-inferior thalamus, has close proximity to ventro caudal thalamus, which bring sensory, which responsibly for this. This is the patient for just. This patient is a policeman, active policeman. He cannot do signature. He cannot do his job. He cannot do his job well because he cannot use his right hands. You can see there's a tremor and a little bit rigidity, and this is the post-op. It's very good tremor control and rigidity. He happens to go back to his police station and can do his job again. This is my old case. This is patient 72 years old with 20 years experiencing rigidity, and she spent her whole life in a bedridden. And at first I don't want to perform surgery for this patient because she was very old, but it turns out that this patient has a good response to levodopa, but has a severe dopa-induced dyskinesia. I want to show you this is the pre-op video. The patient bedridden and start a dopa challenge and start to having a dyskinesia. You see, there's abnormal movement. This is dyskinesia, which induced by dopa, and this is very good for palaeotomy because the palaeotomy can reduce the dyskinesia. This is the patient. Post-operatively, I did the left side for treating the right rigidity, and she start to have the dopa agent again, and and reduce dyskinesia, severity of dyskinesia. This is another case, pretty much the same. Okay, because of times. This is patient. Maybe Dr. Fahmi, or maybe Dr. Fahmi recognize this patient. This is patient who has received left calamotomy in National Hospital, and then after few months, and after 6 months or more, he came to me and he wants to use BPJS, and for his second surgery in the contralateral side. And so I did the right unilateral left thalamotomy, and this is the result. It was a very good result. Okay. Okay, this is my conclusion and suggestion. So brain lesioning for PD combined with dopamine offered a good result in improving quality of life. And brain lesioning surgery is doable and feasible because it is covered by BPJS. Therefore, brain lesioning should be offered and be choice of a therapy for PD patients who meet surgical criteria. And for myself, this is all we need is a long-term follow-up with objective instrument, UPDR score. It is needed to evaluate the objective effect of brain lesioning in PD patient for a long time. Thank you very much.
Okay. Thank you very much, Dr. Agus. Very complete, nice, and very clear presentation about the lesioning, brain steatotic lesioning for Parkinson disease. So we have one or two questions for discussion. Is any have a question for Dr. Agus Aulia from panelists or another speaker?
Okay, thank you very much.
Fahmi.
Okay, Dr. Fahmi.
Okay. Very good presentation. I very enjoyed the presentation. Excellent presentation. We hope many universities in Indonesia can bring like this for stereotactic surgery for movement disorder. I think it is very good achievement. Congratulations, Dr. Agus. Thank you very much.
Thank you very much. Thank you, and thanks to you. Because of you, I was inspired to follow your step to do the functional neurosurgery for movement disorder.
If there are any others, I have one question for you, Dr. Agus Aulia.
Yes, Dr. Ingas.
Yeah. I wonder that we have now, maybe three of us there know that also the stereotactic lesioning have a price for that. And I think the BPJS is not fully covered, or not all the things in the kind of the surgery can balancing with the payment from BPJS. How do you have trick for this kind? Maybe the codes of the BPJS for this kind of surgery or something?
Yes, the code for the disease ICD-9 is G20. It is Parkinson disease, and the ICD-9 for the therapy or the treatment or the surgery is craniotomy, 01.25. At first, I was trying to do many to list all of the BPJS code. I list craniotomy, I list lesioning, I list ablation procedure, but at the end, it is eventually they pay the same. They pay the same. The same as craniotomy, and for RSPAD, it is type A hospital. It is quite high, about 25 to 30 millions, and 25 and 30 millions for the surgery. The surgery is awake surgery. it doesn't need a lot of equipment, doesn't need of wasting medical wasting, or it doesn't need long inward. It's only 3 days on the ward, and then after that they go home. We still have sisa. We still have rest of the money. Yes,
Yeah.
we still get paid. Yeah, that's what is important. Yes, I still get paid for that.
Okay, understand. This is nice information for us. Okay,
Thank you.
is there any question? We have to move to another presentation because the time is limit. So in the next session, we want to invite Dr. Mustaqim Apriyansa Ramadan, who is present about resection of piriformis muscle in piriformis syndrome. Time is yours, Dr. Mustaqim.
Oke, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good evening for all of my teachers and also seniors and also professor. Today, I will try to present our case about the resection of piriformis muscles in piriformis syndrome. My name is Mustaqim and I'm from the Airlangga University Neurosurgery Department. And this is my abstract that I would like to explain in my PowerPoint. And the piriformis syndrome itself, it refers to pain that caused by impingement and of the sciatic nerve of the piriformis muscles, causing the complex pain that come from the buttocks, sciatics, and also both combinations, and also come from the hips. But the diagnostic of this kind of syndromes is really complex and also challenging. The combinations of history, physical examinations, and also imaging modalities, and also the very important things is diagnostic of injections that can confirm the diagnosis of piriformis syndrome. The conservative treatment for the piriformis syndrome is of course the first choice of this case, but the surgical release of the piriformis muscles is also the options to decompress the sciatic nerve that impingement of the piriformis muscle itself. Filler from the study performed the surgical resections of the piriformis muscles for almost 64 patients that obtained 82% initial and also 76% long-term and also a good excellent outcome. This is my case. 72-year-old male with chronic low back pain with recent onset of left leg pain for almost 2 months, tingling and also sore at left foot and radiating pain. Predominantly, the pain is come from the sacroiliac region. This pain is diffuse, poor localized, radiating, aggravated by activities, daily living, especially walking in long distance. And the pain is relieved by resting his leg and also got some pain relief from medicines. This is the timetable of this patient. This patient came for the first time at 2011. He presented the pain at the same site, but at that time we choose to do the exercise, physical therapy, and also the patients have take some pain reliever medicine. And 2016, the patient came again with the same side pain, and the patient have done the MRI of spine. The result is spondylolisthesis of L4 and L5, bulging disc L4 to L5, facet hypertrophy, and also L5S1 disc extrusions, and also impingement of the L5 exciting nerve root. So we decide to do some injections of the spines and also injections of the piriformis muscles, because we have to think first the causing of this kind of pain is, we have to think that the problem is spine at first. But we also confirm the patients with the injections of piriformis, and after the injection of piriformis muscles, the patients got nearly complete resolutions. But less than 3 months, the patient came back again at April and 2017 with the same pain. So we have done the injections of piriformis again, and patient have nearly complete resolution at least less than 3 months. And August 2017, the patient got the injections of piriformis and also S1 joint injections. So we decide to do some surgical decompressions of these patients. From the historical examinations and also physical examinations, the patients at rest, he always want to externally rotate it. And from the straight leg raisings, the patient already have feel the pain at 40 degrees. And left lower extremity flexions at fair positions, he feel really pain. And also at the piriformis muscles strength, and also we do the palpations of the piriformis muscles, the patient feel really pain. So we have to think that this is maybe some kind of syndromes that come from the piriformis muscles. But also we still think about the S1 radiculopathy. So we do the diagnose about the injection of piriformis, and this is confirmed that these patients is we have to diagnose with piriformis syndrome. But after the therapy of injections, we have so the timetable, the patients come again for less than 3 months. And the patients have done the surgical resections of musculus piriformis and also neurolysis of sciatic nerve. And in the operations, we found that the sciatic nerve is pinched by piriformis muscles and swollen of the piriformis muscles itself. This is some difference anatomical, because the sciatic nerve have to pass through the piriformis muscles at anterior part. But in this case, the patients, we found that sciatic nerve split the piriformis muscles, and also the piriformis itself got swollen, maybe because of the macrotrauma, and also maybe because of the patients have some exercise. So the goal for these patients is making free the sciatic nerve that surrounded by piriformis muscles, and also followed by injections of corticosteroid at the piriformis muscles. The surgical procedure, the patients got the complete resolutions and still followed until 6 months. The patients got the minor complaint. So we can discuss these patients. I have felt that these patients got the piriformis syndromes and also pain at the buttock, and also radiating pain at around the hips until the buttock of the patients, and also worsening at sittings at almost 20 minutes and relief by standings. We also know this kind of pain is wallet neuritis, and also the patients got the extreme pain when he stretching piriformis flexions, or we call it the vertex. The vertex of the patients, the patient got really pain at the buttock of the patients. And this is the Fishman clinical criteria. We found 3 of the 4 criteria of these patients. The positive last sex of these patients, the patients still 40 degrees and feel really pains, and also tenderness of the sciatic nerves, and also the vertex is positive. But in this patient, we didn't do the electrodiagnostic study of the muscles. And also from the clinical diagnostic of the nerve entrapment, the LASIK test, PES sign, Faber sign, BT test, and also FAIR test, the patient is positive. So this kind of piriformis syndromes, the challenging is the how to diagnose the patients, and also how we can get the complete resolutions of the patients. And from the study of this article, the surgical treatment of the piriformis syndrome, we have the algorithm for the piriformis syndrome. We have suspected the piriformis syndrome from the physical examination, patient history, and also pelvic CT or MRI. But I have told before that we also have to think about the spine problem. So we confirm the lumbar CT and also MRI, but in this case we haven't done the EMG, but we have done the spinal block. So we think first, at this case, this is the other disease. We think first that this is the spine problem, but after some appropriate treatment, we have done several serial of injections in the spine, but this is unsuccessful. So we think that we have to think the other disease. The first things that we have to think about the piriformis syndrome itself. So first we change the behavior, medication, physical therapy, but we haven't done the shockwave corporal. But we have done the steroid injections of the piriformis. So it can confirm that this is one of the symptoms of the piriformis syndromes. And the patients haven't got the complete resolutions of the pain less than 3 months. So these patients have felt the pain for almost 7 years. And the complaint cannot get the complete resolutions. So surgical decisions is needed for these patients. This is surgical approach of these patients. In previous journal, we have seen that some surgeons do this surgery by lateral decubitus, but in this case, we have done the prone positions. And then we have found the gluteus maximus and do the blunt dissections until we found this anatomical area. This anatomical area, this surgical landmark is greater trochanter and also PSES at this site. The piriformis muscles is getting through from the anterior part of the sacrum through the medial part of the great trochanter, and the tendon is come from the great trochanter. So we can see here that piriformis muscles here is swollen, and we have known that this is the tendon here from the anatomical landmark, and we find here that this is the tight piriformis muscles that pinch the sciatic nerve. So the goal of this surgery is to decompress and also we give enough space of the sciatic nerve. So we cut some the tendon of the piriformis, and then we evaluate is that enough space for the sciatic nerve or not. This is we evaluate the patients from the inferior part and also from the superior part. In the inferior part, we get some space of the sciatic nerve, and also from the superior part, we also got the enough space of the sciatic nerve. So we also evaluate from these patients the clinically, and we got the satisfactory clinical results. And with the patient is really satisfied because he struggled to find complete resolutions for almost 7 years for the pains. So with the surgical decompressions of the piriformis syndrome by resections of the piriformis muscles could be the best options of the patient that failed to respond successfully for the conservative treatment. Thank you very much.
Okay, thank you, Dr. Mustakin. That is a nice presentation that I have. I just know today. Yeah, surgical for piriformis syndrome. This is
Yeah.
interesting.
Thank
So,
you.
is there any question from the panelists or other speaker? Okay. Before from another panelist or speaker, can I make a question for you, Dr. Mustakin?
Okay.
The first is you said in the pathway that you have to try conservative treatment and also the steroid injection also first before you doing the surgery resection. This is we have trying attempt to 3 months.
Yeah.
Is that right?
Right.
So how many minimal invasive treatment we have to do it up before we make a decision for the resection?
Actually, from this article and also some article that have done the surgical treatment for the piriformis syndrome, actually the steroid injections just once. When we cannot complete the complete resolutions, we cannot achieve the complete resolutions of the injection of steroid of the piriformis for less than 3 months, we have to think about the resections of the piriformis to decompress the piriformis muscles, because for the first time that the patients got the steroid injections for the piriformis muscles, but the patient got the resolutions. It means that we have confirmed that this is the piriformis syndrome. But in our goal is to get the complete resolutions. But if we cannot get the complete resolutions, we have to think about the surgical resections. But in this case, the patient is a doctor, obstetrician, but he didn't want for the first time he didn't want do the surgical. After the 3 times of injection, steroid injections of piriformis muscles, the patients finally wants to do the surgical resections. From this article, we can see that this is the first time of steroid injections. We cannot achieve the complete resolutions. We have to think about the surgical resection.
Okay, so do you have thinking that maybe because of the maybe like a contracture or like fibrosis of the muscle can make prolonged healing by is not well result by the injection because of maybe the pathology of the piriformis muscle?
Yeah, of course we have to think that the problems also come from the piriformis, but after we do the resections, we inject the corticosteroid at the piriformis muscles. We really confirm that after the surgery, we have got the enough space we have to check that really if the patients get healings, the patient cannot get the incomplete resolutions. Maybe some cases the patients cannot get the complete resolution, but this after almost 1 to 2 years. the patients come again with the same problems. But we have to think also this patient still have the problem of spine. So after 2 years of the surgical sections, we also do the injections of spines again and also the injections of the piriformis muscles.
Okay. Is there any question?
I think something.
Okay, Dr. Fahmi, please.
Yes, it is excellent presentation and very good. Yeah. The most important thing is about how to diagnose the diagnosis of the piriformis. We must make sure that, like the constructing said, that the most important is diagnose to diagnose it is piriformis syndrome or not. It is the source of the pain is from piriformis or from the lumbar. And like the constructing said, the injection is for diagnostic and for treatment. For diagnostic, if it is better good after injection, which means that the piriformis is the cause. And if it is recurrent, you can inject again. And if the second injection still recurrent, you can do the compression of the piriformis syndrome. But during the compression of the piriformis syndrome, please be careful that many types of piriformis syndrome. That usually in this case, in the second case, I think it is type 1 piriformis syndrome. And there is about six of type of the piriformis syndrome. Be careful because sometimes in the another type, the nerve is inside the muscle, hit the muscle. We must be careful for that. Make sure that you are not cut the nerve during the surgery. Okay, excellent presentation. Thank you.
Thank you, Dr. Fahmi.
Okay, and one more last question for you, Dr. Mustakin. So in terms of the technical of resection, do you have totally cut off in the piriformis muscle and make a gap or prevent the fibrosis and maybe become entrapment again by the fibrosis of the surgery?
We can see here. You can see here. Actually, we cut all the piriformis muscles until we found enough space. Because actually, the piriformis muscles and gemelli muscles and also obturator internus muscles is combined to one tendon. So the functions of the patients after we cut the piriformis muscles still have good functions. So after we cut, we give the corticosteroid to maintain the process of healings, and also we give enough space for the piriformis, for the sciatic nerve to have enough space here, because our goal is to decompress here. We cut all the piriformis muscle here because the piriformis muscle is really small with the one tendon here.
Just only cut it, not make a gap. For example, take out for me 1 centimeters in the edge of the each side. So make a gap, so prevent for the unification after surgery also again. Just only cut.
Cut, yeah.
Okay. Thank you very much for your nice presentation. It's good for us to know this kind of technique. It's a simple but very important for patient. For the last, because of this already, all the speakers already speak with a very nice presentation today, and from the 1 p.m. until now, I think we can close, and I will give this session to Dr. Dira as a host in this seminar. Please, Dr. Dira.
Thank you, Dr. Made. Okay, now, ladies and gentlemen, that's it for the second session of the Functional Satellites of Indonesian Neurosurgical Seminar. We thank to all the panelists and all the speakers for sharing with us, and thank you to all the participants. We would like to thank you for making the time to join us today. Before we finish, can we show every person's video, please, so that we can take a nice group picture before we finish? Okay. Okay. Dokter, udah semua? Okay, please wait for a moment. I'll tell you when to smile. Keluar semua. Oh, oke. Oke, sip. Please smile. Okay. 1, 2, 3. Thank you. Okay.
Thank you.
Thank you, bro.
Thank you, Profesor Renal. Thank you, Dr. Fahmi, Dr. Ari, Dr. Musakin, Dr. Agus Aulia, Dr. Yuris.
Terima kasih Mas Jas.
Terima kasih.
Terima kasih Mas Fahmi, Prof. Reri. Terima kasih.
Prof ininya terima kasih banyak, bikin kita semangat.
Ya, jangan lupa join meeting plenary ya, sudah ada di chatnya linknya.
Oh, oke.
Terima kasih.
Bye.
Ya, bye.
Kan.